Good morning, ladies and gentlemen. My name is Regina Mariam Namata Kamoga, the Executive Director of Community Health and Information Network Chain in Uganda, and also founding board member of the World Patient Alliance. I'm delighted to be here today during the first Africa Patient Regional Meeting organized by the World Patient Alliance. We know that patients across the globe face healthcare challenges, but it's also true that patients in Africa actually their challenges are even worse. Over 615 million people in Africa can't access essential healthcare. The services available are very low quality, and there's a low sense of ownership and trust in healthcare system. Other challenges include issues of affordability, availability, proximity, which sometimes leads people to go for traditional alternatives and other unsafe practices that impact their health care. Africa has 17% of the world population, but accounts for 23% of the global burden of disease. We know that also 11 million Africans are falling into poverty every year due to high out-of-pocket costs. It's also true that there's low priority of healthcare, where many governments have not reached their target of the Abuja commitment. Issues of human resource capacity, issues of healthcare expertise and infrastructure and supply chain challenges, but also the issues at the patient level, including low health literacy and other issues. The above are only a few. The self-care problems are enormous. The World Patient Alliance thinks that universal health coverage is a solution to all these challenges affecting the African patient, and looks at the key actions that need to be advocated by the different key stakeholders. These include financing. We need more budgets committed to health. Services need to be patient-centered to address the needs of the patient in terms of the quality and safety, equity, ensuring that targeting the poor and the marginalized are not left behind, ensuring that we reach the last mile patient, preparedness in terms of strengthening health security, as well as governance, political and institutional foundations. We need the leadership, the political leadership, to be committed to ensuring that all patients receive the care that they need at the right time without any financial hardship. The first Africa Patient Regional Meeting is one of the pathways for achieving universal health coverage. And the theme for this regional meeting is raising patient voices as a pathway to quality and safe care in Africa. I would like to acknowledge the team that worked very hard to ensure that this meeting is a success. The World Patient Alliance Office and Board, Doni Ndanzima Cyrus, Irene Pagire, Albani Goitanire, Rebecca Chirenga, Alphonse Mbarushimana, Christine Motena, Roslyn Odero, Kwame Apia, Dr. Groom Godfrey, Mercy Kukundakwe, Dr. Joshua Atepo, Cecilia Nantume, Danjuma Ada, and Ziwa Hillington. Without the efforts of this team, this regional meeting would not have been possible. We acknowledge all their efforts. The meeting objectives include providing patients the platform and opportunity and raise patient voices regionally as well as globally, promoting interventions under the Universal Health Coverage Framework of Actions, and creating a pathway for sustainable platform for patients, organizations, and partners to collaborate and foster patient safety interventions. We looked at the short-term and long-term outcomes. And the short-term outcomes are convening patient organizations, key global development stakeholders, policy teams, and industry representatives, and sharing resources on the application and results of the Universal Health Coverage Framework of actions to achieve quality and safe care. The long-term outcomes are creating the WPA African Regional Membership Steering Committee to build capacities of patient organizations to promote safe care, creating an online information sharing and knowledge management portal for tracking the progress of universal health coverage interventions, as well as mapping out and forming a network of the African continent patient advocacy working groups to advocate patient quality and safe care. We're looking at this meeting not only just as a one-off, but continuing to build a strong network of patients to advocate for these issues that are going to be presented in the different presentations today. We're looking at working together. In my language, we say agali awamu gegalume nyama. Teach together is what bites the meat. So we're looking at these collaborations, working together collaboratively through a mutual relationship to ensure that we advocate for patient-centered healthcare and ensuring that patients are safe when they're receiving their care. We believe that patient safety and quality care is very possible if only we all work together. I thank you very much for participating in this first regional meeting.
This shall be in from Uganda. We have a lot of work in terms of patient safety and quality care that is done, and we'll hear from them intriguing stories on how they've managed to ensure that there is patient safety, patient-centered care in terms of accessing care, the limitations that they are having, of course, the bottlenecks that they encompass in terms of pursuing patient-centered care. You realize that we are interested in, but of course, we are faced with a number of hiccups, a number of bottlenecks, and we are really challenged. It is very difficult here in Uganda for patients to engage effectively with the healthcare system. One, there is a big challenge in terms of information. You find that our patients are not yet empowered, fully empowered in terms of information that they need to effectively engage with the healthcare system, to effectively engage with healthcare providers. They need empowerment in terms of rights, in terms of what does it really mean? What is the continuum of healthcare patient safety? That information is still lacking, and we need fruitful dialogues and engagement with the national system, with the government, with different partners, different stakeholders, so that this effort can be effectively trickled down to the grassroots. So here, what Shane is really doing at the moment is to ensure that we engage right from the grassroots, empowering students, empowering young people, disseminating the concept of patient safety to the children, because we realize that once you start it at a very early age, so that students in schools get informed, they get empowered, they get to understand their rights, they get the continuum of the patient's charter, what is universal health care coverage, what is their role. We thought it can be something that can really help to ensure that we have patient safety, right, starting from the grassroots. So members, you also had a very interesting discussion from Hussein Jaffrey from the World Patient Alliance, the executive director. He highlighted the principles of the World Patient Alliance, but also the principles of patient safety, what patient safety means, how far they've transpired in terms of channeling patient safety, the direction of the World Patient Alliance, in terms of spearheading patient safety, but also empowering different economies in terms of in terms of boosting patient safety goals and universal healthcare coverage. And you realize that we are having also, he went on to highlight that we are having the Rome meeting on patient safety. Please, we shall be, during some breaks, we shall be sharing with you a link that you can use to register for the Rome meeting. He highlighted that in this meeting, we are having different key stakeholders, different partners, big players in healthcare that will be joining this meeting. It is a fruitful dialogue where we expect fruitful deliberations in terms of healthcare and patient safety. So once we flash the link, ensure that you are able to register so that you attend the Rome meeting. You realize that this meeting also fits into the Rome meeting, and a lot is happening in terms of the universal healthcare coverage and patient safety spectrum. So members, as your host, please, I urge you to type in the chat, continue typing in the chat. We are going to have time for all those questions, for all those intriguing questions, where we are going to clarify, discuss, and ensure that everything is clarified, that we have a fruitful deliberation. So members, let me first check on something here. There is a connection I need to work on here. I'm here with you again. Members, allow me to introduce now other speakers. The subsequent speakers, we are going to give patient stories from Uganda. They are from Story Mike Uganda. And these patient stories are going to be delivered by George Wanka, who is an advocate of the High Court of Uganda, an associate at Vitalex Advocates, a startup law and legal technology focused law firm, a poet as well as a founder and creative director at Story Mike Kampala, a live-themed monthly amateur storytelling event that happens at the Uganda Museum every last Thursday of the month. Please, having heard his rich profile, please, George Wanuka, the floor is yours.
Morning. Morning, everyone. Yes, my name is George. As Donnie said, I run a live monthly amateur storytelling event, and what we do is mix real life true personal stories and craft them in a way that they create empathy and that people create connections from these stories. Today, we are doing that with patient care, which is a very important topic to the World Patients Alliance and the World Patients Day. The World Patients Day. Today, I have with me David Kanje, who's going to talk a bit about himself, and it is his story that we're going to base on. We have been seeing a movement from patient care focusing on treatment. What time does a patient get treatment? To ensure what drugs is the patient taking? Matters to do with overdose. But there is a movement now to look at patient care as an all-round thing, as prevention and management of our patients, not just physical, but also mental welfare. And David's story relates to patient care in that line. Maybe, David, I do have a few questions before you get into your story. Please, what do you want people who hear this story today to take away from your story?
Thank you very much for having me here, and thank you to the organizers of this wonderful conference. My biggest wish for everyone who is here and for anyone who will get to watch this video is that, you know, at the end of the day, you do not know the day you wake up and you'll be in need of help. You do not know the day when you will be the stranger on the other hand, and then you're in need of help. For me, my case is I'm a beneficiary of patient care from a stranger who took me in when I was at my lowest. What I learned from that time is that everyone of us can be in need, can be the next person in need of patient care. So the need for empathy, kindness, and care for all people is called for and called upon. But mostly, especially, my wish is that we understand and appreciate those who go out of their way to offer such kind of service. Yeah.
Okay, David Kanje, tell us a bit about yourself and what you do.
I'm a writer, I'm a blogger, I'm an editor based in Entebbe, Uganda, and I've been on the Kampala scene for close to 10 years now, mainly focusing on content creation for online platforms. Travel, I'll take it a bit out of the context. When we talk about, for example, today, when they talk about the fourth industrial revolution, they say one of the things that are not going to be substituted is creativity and empathy. And in a world that is very fast and very, the world is on its toes and on its feet, it needs, people are not so much into empathy. It's so mechanical. People are running, competing. We have social media that's driving people crazy with competition, comparison, and the workplace is too demanding. And there's so many factors which are pushing people to the wall. And there is need for empathy. There is need for someone to stop and say, "Hey, I got you." There's need for someone to say, "Okay, it's okay. Take a day off. We understand." So for me, if we could get ourselves there, one, as the providers of this empathy, but also on the other hand as beneficiaries, would make this place a better place than maybe we found it.
Thank you, Kanja, and I agree. Now, Kanja has a story of when he experienced patient care, and as I've explained that Story Mike, what we do is get these stories and bring them to you. So I'm going to leave the floor to Kanja. So Kanja, take it away.
Thank you, George. Thanks for the opportunity to share my story once again. My story is, I'll try and summarize it for you. On 25th June 2010, as a student in my senior 5, I'm called out of class to go home, and the news was my dad had passed on. So in that panic and all that, I packed my bags and go home. And the following day, on 26th June 2010, we had a funeral service, and we went to go. We went for the vigil at home. Later that evening, I was with my cousin as we, running around, putting things together for the vigil. We needed to go and get fuel for the generator that was running in the night when we got a motor accident. So I broke my leg and I had to be carried back to the hospital. The good thing is that we still had an ambulance. The ambulance which had carried the casket home was still on site, and so they drove me back to the hospital. That was at St. Stephen's, Belere. And I was glad that when we got to hospital, we found a lady who was on duty, the nurse. She's called Joyce. Joyce took care of me because everyone of my family members was back home. I was only with a friend of my dad and the ambulance driver, and we were in, I reached hospital around 1 a.m. So it was too late to go for the x-rays, and also they gave, Joyce gave me first aid and stayed with me till morning. At around 6 a.m., we drive out with the ambulance driver and Joyce and go to look for the available x-ray that we could use. We went to a number of hospitals that morning, but we could not find any because it was around the time when shifts were changing. So the people who had worked night shift were stepping out and the morning shift hadn't come in. So we went to about 5 hospitals before we could get one. We found one at Zambia Hospital where the x-ray was done and they realized my condition would be worked on at the hospital. I spent the night. Joyce was that angel I didn't know I was with. She made sure that all through the ride, from the night of my arrival to the ride through hospitals, she kept me calm, she talked to me, and together with the driver, they tried to soothe me, and created a better environment for me. When we go back to hospital, her shift was done because she had worked the night shift, but she didn't leave. Instead, she stayed with me and spent the whole day with me. We were together, practically we were in the room together. She was the only person I had on site. And also the hospital, for one reason or another, didn't have so many patients. So she was there. She was the only person I had. She went out, did shopping for me, got me new clothes, got me food, and stayed with me. She created an environment that enabled me to not to get depressed or to drown myself in what was going on at home, because on 27th, which was a Sunday, was the day for burial. And so everyone, my family, my friends, everyone was home for the burial. And here I was in hospital alone with Joyce. We spent the rest of the Sunday together, and she had to go home late in the night when my brother came back from the burial and joined me and a number of my friends. That's the only time she left my bedside. But the following day, she came back for duty, and for the rest of the 3-4 days I was in hospital, I was there with Joyce. I had not known her before. It was my first time. The accident brought me to meet her, but she created an environment, an enabling environment for me to recover, but also to give me the psychotherapy that I didn't know I needed. So that's how, for me, patient care, every time I think of patient care, I remember Joyce. She's that hero, she's that angel that came to me, that stayed with me at the time when I was hurting the most, and I didn't know that I needed all that help. But when she brought it, I look back today and I'm grateful for Joyce. Yeah, thank you. That's my story.
Thank you, David. We do invite any questions or inquiries, but what we are getting from this story is the main reason that this particular incident of patient care left any lasting impression on David is because, according to him, and maybe this is because we are not so used to this as patients, everyone is a potential patient. That's one thing. Being a patient, it's like tax or death. It can happen to you anytime. You can be walking and get an accident. But because, according to him, Joyce went over and beyond what he felt a normal nurse should be. We've read stories of nurses who, and the fact that Joyce looked at beyond the physical well-being, but also went for the mental well-being, is why I think this story left an impression, a lasting impression on David, that this woman stayed with him when he should have been attending his father's funeral. So, David, what appeals to you most about this experience?
One, the fact that Joyce had to go, didn't have to, but she went out of her way to stay with me, and also she thought things through ahead of time. She created an enabling environment for me to feel at home, for me to forget about what was going on back home, about the barrier and all, but also to teach me a lesson which I was to learn later on in life, that, you know, like you said, every one of us is a potential victim, a potential patient, but also to know that just as we are potential patients, we are also potential patient carers. And we need to have that in mind, that today it's our duty to find a way to care for others when we are able to, and whenever we are in position to. We do not have to limit to the people we know, to those we love, but, you know, we can stretch to even strangers. You never know who will hold your hand next. Yeah, thank you.
Yes, thank you so much. And that is it from us at Story Mike. Enjoy the rest of your day.
Thank you very much. Thank you very much, Mike Uganda, for that interesting story. In the interest of time and, of course, the interest of the audience, we kindly request that we get a 5-minute break. Then we shall be back with the subsequent presentations as per the program. So in the meantime, members, you can have a 5-minute break, enjoy probably a cup of tea, some drinking water, as we prepare for the subsequent sessions. I'm looking through the chat and Harris is doing the same. We shall be having a deliberation about the questions within the chat, but also trying to answer your questions. The subsequent sessions, as you will note, are going to be more interactive, and the audience is going to be overly engaged. It's going to be overly engaged. So members, I wish you a successful and fruitful 5-minute break as we prepare for the subsequent sessions. See you as your host for the day.
Ladies and gentlemen, welcome back from the break. We apologize for the few technical glitches that have happened, and wish for best deliberation going forward. For our next sessions, we are going to listen in from Dr. Ernest Konadu, who is an expert in health and then the pandemics. But before that, we would like to welcome Mr. Donnie Ndanzima to introduce Mr. Konadu so that the presentation can start. Thank you very much.
Thank you very much, Siwa, for those introductions. As highlighted, my role is to introduce Dr. Konadu. Dr. Konadu. So Dr. Ernest Konadu Asiedu holds a Bachelor of Science in Medicine, then is also an MPH Fellow. He is an advisor, an improvement advisor, a field epidemiologist, and he heads the National Quality Management Unit. It's working with the Ministry of Health, Ghana. So Dr. Konadu will be giving us a presentation titled Reaching National Patient Quality and Safe Care Goals through Developing Improved National Preparedness Plans, which include organizational structure of the government. So this session is also having different speakers. It's supposed to have 4 speakers, and Dr. Konadu Asiedu is one of the 4 speakers, and the other 3, I'll introduce them later on as their presentations unfold. But in the meantime, please allow me strongly invite Dr. Asiedu Konadu to take up the floor. Please, you are welcome.
Dr. Ernest, please, you can unmute yourself. You're muted. Thank you.
Okay, so thank you very much. Good morning to all of you. I guess you can hear me now.
Doctor, I can hear you.
Thank you, thank you. So yeah, thank you for the good introduction that you did. So I won't waste too much time. So will the slide be rolled over there, or I may have to roll the slides from here? Okay, so I think next slide, please. All right, so I just want to acknowledge the National Center for Coordination of Early Warning and Response Mechanism. That is where I'm leading health and pandemic related issues, and also the leadership of the Ministry of Health, the Minister, the Deputy Minister, Chief Director, and the directors of the ministry, the various heads of agency, because Ghana has a very pluralistic health system, the directors of the agencies that we continue to work with, and the various development partners, and most especially our patients, the community, and the family, for which reason we have to do this, and various collaborators and the media that we've worked with. On the right side, you can see a few of the logos of some of the partners that we work with. Next slide, please. So the presentation will go through this outline. We can move on to the next slide. So a bit of the profile of Ghana. Ghana is located within the West African, on the western side of Africa. And then also, as you can see, it has 16 regions at the moment with a population of about 31 million. Also, life expectancy has improved over the period, getting close to about 65, with male-female distribution somewhere with the females a bit 2 years above that of the males. But it has a land size of close to 240,000 square kilometers. Next slide, please. The good thing is that Ghana is bordered by 3 French-speaking countries, and then the Gulf of Guinea is at the lower side. So Ghana has a very pluralistic health system. The Ministry of Health is the policy formulating ministry, and then ultimately has a number of agencies, about 23 of them. And these are all categorized into various forms. So I'll take us through the various forms around here that will help us to understand how we work closely with our patients and the community. So it's categorized into service delivery, where we have about 10 of them, with the Ghana Health Service being the main public health institution that runs to the community level. There are 5 teaching hospitals, faith-based organizations, including Ahmadiyya, and then also the Christian Health. Then we have the self-financing private sector, and then we have the quasi-government institutions, which are other non-health institutions that also provide health service in the country. Again, Ghana aligns with WHO and also focuses very much on traditional and alternative medicine practice. And there are also standalone institutions that provide traditional alternative medicine. When you move to the right side, as far as we are achieving universal health coverage, and we're saying that without any financial barrier at the point of use, Ghana has a national health insurance scheme that is run by a national health insurance authority. And ultimately, there are some other private health insurance systems that also work within the country. And few people who do not belong to any of these may have to do out-of-pocket payments. But the country is working closely to ensure that everybody is covered under the national health insurance, which ultimately will help us achieve the universal health coverage. If you come down, you will see the undergrad and postgraduate training institutions that ultimately be the inputs into the health system, and they train health professionals and then also do postgraduate training to build additional capacity. But each of these health professionals are regulated by at least one professional regulator or the other. And then also the equipments that we use within the system are also being regulated. All these are embodied in the Health Facilities Regulatory Agency, which regulates every health institution in the country, both public and private. And then being supported by the National Blood Service, the National Ambulance Service, together ensuring that the patients and the community, as we see here, will begin to experience quality care, and then also their safety will be assured. In that sense, the ministry recognizes the various coalition of NGOs in health, also recognize the community, the patient, and the family as a major stakeholder within the health space. And we work closely with them to make sure that their inputs, are fully respected in the way that they receive care in the country. Next slide, please. So at the moment, Ghana is adopting the network of practice with the model health center at the center, as we can see here. So this is going to be the hub, just like a bicycle tire, which has the hub and then ultimately the spokes where within the health institutions are connected. So it could be a workplace infirmary, it could be a school infirmary, it could be a community pharmacy, any form of clinic, both public and private, maternity homes, the community-based health planning and services, and then also market clinics. Some of them are mobile, but ultimately will be linked to the model health center at the hub level, and that would ultimately be referred to a district hospital if there are any challenges that are not being able to manage. But you can see that around it, we are looking at the primary healthcare financing, which ultimately the National Health Insurance is working. The ambulance service is there to assist referrals, the various professionals, and then also facility regulation, which is the foundation of quality and safety, telemedicine to connect these facilities if they are not able to go there real time. And then also the major stakeholder we are looking at is the community and also the various district support systems that are available. But we can achieve all these things through both pre-service and in-service capacity building. Next slide, please. So a little bit of introduction. I think during the presentation, some of these things have been talked about, but I'll focus a bit as far as Ghana is concerned. Patients do know that, yes, ultimately, when they come to the hospital, they might not always receive the care or they might not be cured, but at least they are not expecting that we will harm them when they come into our setting. Now, global data is saying that one out of 10 patients who visit our health institutions may be harmed, but we do believe and we know strongly that the health system, is also aware that we can also lessen some of these patient burdens. Within the low and middle income country, there may be a few challenges because some of the data might not necessarily be, reported. However, we know that we can do something better to ensure that our patients, our family, and the community, will live within a harm-free environment. Next slide, please. So the current status of patient safety within the country, Ghana has a national healthcare quality strategy in which the patient safety is fully embedded. Ghana, before the World Patient Safety Day was launched in 2019, Ghana has been part of the global patient safety interventions. The patient safety one, the first one, which was hand hygiene. The second one, which was safe surgery and surgical safety. The third one, which is medication without harm. And currently, as we are moving on with the fourth year of the launching of the World Patient Safety Day, medication safety, and we are towing the same line. So Ghana has prepared itself. On the extreme right, as you can see, we are working towards next month having our 4th annual National Patient Safety and Quality of Care, slated between the 13th and the 15th, and ultimately the major launch that globally happens on the 17th of September 2022. Next slide, please. So what does it entail to have a very, to implement or have a very strong patient safety activity or intervention in the country? You need very strong leadership. So this picture, as you see here, is the Honorable Minister for Health, together with a colleague of mine, taking him through what we call the community scorecard. And so clearly you can understand that leadership takes this very seriously and go on the ground to appreciate what typically happens in the country. The second one is also looking at identification of the various gaps that inhibit patient safety and the outcomes. And you can see on the left here that we, in terms of data collection and then data use, as far as electronic and real-time reporting is concerned, this is looking at the community scorecard, which allows patients and the community to make inputs into the way service is being provided and be able to share their experiences when they come in contact with the health system. Now, the last one is looking at partnership with patients to understand what truly matters to them, focuses on the experience of care and accountability. And you can see how the community looks at service within the country, makes input into it, and as well as also contributing their quota where there are challenges within health institutions, and they are able to support in providing that kind of service to make sure that we can close the gap between the providers and the consumers of the service. Next slide, please. So for Ghana, we do have a very structured quality and safety organogram where the Minister for Health takes full responsibility as far as patient care is concerned, and has what we call the Interagency Leadership Committee, where all the agencies meet with the minister every quarter to deliberate on issues as far as patient safety is concerned, and how each agency's role, will work towards ensuring that every patient and the community that we come in contact with is safe. Now, under that, we have the National Quality Strategy Technical Committee, which is also chaired by the Chief Director of the Ministry of Health. And the Secretariat that oversees that work is the Quality Management Unit. Below this, the various agencies have their specific role that they play. For regulators, for professionals, they make sure that every health provider in the country, as far as provision of care is concerned, and the professional is fully regulated by the specific regulator, and make sure that, yes, they upgrade themselves with knowledge. And this runs through the region, to the district, to the facility. And Ghana has this structure going down into the community. And at each of the levels, a patient group or a community member plays a critical role and make inputs into the services that we do provide. Next slide, please. So we want to talk a little bit about some of the strategies and the successes that we have achieved so far. You can see the involvement of the Minister for Health. You can see the Health Facilities Regulatory Agency working closely to recognize what we call the Safe Care standards for quality certification and accreditation for health facilities in Ghana. At the moment, the Christian Health Association of Ghana has adopted the Safe Care standards, and they are using that to ensure that every health institution meets the minimum requirements, and the Health Facility Regulatory Agency has adopted and has is using that, recognizes that Safe Care standards for accrediting health institutions. During this COVID period, WHO has worked also closely with the Ministry of Health and been able to look at some of the adverse events following immunization and adverse drug reactions in some of the regions in the country as far as patient safety is concerned. We've been able to launch the Ghana standards for improving the quality of care for small and sick newborns, since they are very special and need specific attention. And then also the Ghana standards for improving the quality of care for children and young adolescents. So all these, looking at the community involvement, puts us in a way to have a better appreciation of how we can work closely with the patients and the community to secure their safety. And ultimately the community scorecard, which is the major guide that gives the patient and the community the opportunity to also make inputs and inroads into the system. Next slide, please. So a bit of some details around the loaded slide as far as the pictures are concerned. So we have a very good governance structure within the country. We protect the health workers. During this COVID, there were a few challenges. And last year, the World Patient Safety Day also focusing on patients because, and then also the providers, because the one who must provide the service must be safe to be able to create that enabling environment to work closely with the patients to ensure their safety. Then we also ensure surgical care. Next slide, please. So improving the knowledge and the learning in the patient safety. So capacity building is very important for both the providers of the service, and from time to time, as we continue to engage the community, they also are build their capacity are built to be able to understand and also contribute whenever they come in contact with the health system. So the community scorecard is a very good platform where the consumers also learn to understand what they truly expect from the health system. And then the providers can also have a better understanding of what truly matters to the patient. But we've gone through a number of opportunities like the safe surgery checklist to minimize harm to patients, using the quality of care network that also focuses on patient and family participation. And then ultimately the 5 moments within the medication safety arena. And even for this year, the focus is more on medication safety. Then raising awareness for patient safety. Since we launched the World Patient Safety Day, Ghana continuously, having some celebration around the patient safety arena. And as I mentioned, next month we are going to have it. And media engagements, that also gives the opportunity for media to be engaged by the community and to share ideas. And of course, we do display our patients and then also the patient charter in all health facilities for patients to understand exactly what the service is supposed to provide. And then they also look at their responsibilities towards the health system. Next slide, please. So these are some pictures to show capacity building for health workers, and then to make sure that they can meet the needs of the patient. Next slide. And this one is looking more at the community scorecard and how the community plays a very important role. So you can see that this is where they assess a bit of capacity building also for them to have a better understanding of how they can assess the health institutions. And this is done at their convenience. If they have any they can sit under the tree to do some of this assessment. And ultimately, in terms of accountability and contributing their quota, community are able to support the health institutions. They sometimes will do where there were challenges in some institutions, the health facilities located there, but water was a bit of a challenge to them. Community contributed because their own people using the facility. And there have been instances where the community also playing a major role supporting the health institutions as far as infrastructure development are concerned. Next slide, please. Next slide, please. Okay. So again, opportunities to minimize harm to patients as far as infection is concerned. We are looking at the antimicrobial resistance policy and then also healthcare waste management policy and guidelines. All these are made available to both health workers and also the consumers so that we'll be able to work together to make sure the patient is safe and the provider is also safe. We've been able to ensure appropriate use of quality medications that are readily available, the Food and Drugs Authority would ensure that they also continuously do some post-market surveillance so that, medications that we give to our patients are safe. During the COVID, we also have our med safety apps where patients and consumers can readily report adverse events or following immunization or drug reactions that patients are likely to come in contact with. Next slide, please. So we're also promoting partnership and expanding funding sources for patient safety. So implementation of the scorecard is one of them. The ALMA Secretariat has been very instrumental supporting Ghana as far as the medication safety is concerned. In addition to this, we are also looking at the continuous celebration and ensuring that the patients themselves come to share their experiences on such platforms. They tell us exactly what they expect from us, and they also make presentations during the World Patient Safety Day. So these things are really happening in the country. Now, when you come to surveillance and research, blood safety, medication safety, as far as the Food and Drugs Authority is concerned, and some hospital reports on surgical site infections also into the DHIS that gives the opportunity for us to share, some of these data with the consumers during our open days. Next slide, please. So all these great things that I've mentioned are not without challenges. Yes, we do also have some challenges that we are working closely to improve. So, for example, inequitable distribution of health infrastructure, the staff and equipment that are being used, and then also the financial allocation of resources as far as the budgeting is concerned. We do have some challenges that currently we are addressing. If you look at things around the infrastructure, the government has a policy of what they call the Agenda 111, building 101 health institutions and ensuring that every district and every region has the requisite health facility to provide services to the community. Financing too, we need to be a bit more deliberate to ensure that we allocate financing to or funds to the various health institutions. Some staff may also be a bit more demotivated due to one reason or the other. It could be challenges with not having requisite equipment to work with, and some remuneration or allowances for people who also ultimately work extra. We do have some cultural and religious, challenges that may prevent us from also providing that kind of quality care, because patients may also choose other forms of services within the community. But ultimately, we are looking at some sustainable ways of ensuring that the patient safety teams, the quality teams, would be able to do what they need to do, because we do have some challenges with staff attrition and all that. Next slide. So we are also drawing inspiration from the Global Patient Safety Network with Ghana. A lot of the health workers are part of that network. So we also do get a lot of updates, and we do know what goes on within the global space, and we can do some deliberations and discussions around there. Developing some operational guidelines, to regularize that also within the health institution as far as patient safety is concerned, to implement those governance structures at all the levels for patient safety, as is, I showed on that organogram. Then we established some of the measurements. We do know that in Africa, in low and middle income country, not all these safety challenges may be reported. So we continuously encourage the staff to report this, because it's the gaps that can help us improve the system, and then getting some strengthened incident reporting systems so that even near misses are also documented, to make sure that we can collect all the data to improve the system. Then increase also health worker education on safety culture and strengthen the various partnerships with the community. Next slide, please. So I would like to thank all of you for your time, and then we will be standing by for further deliberations and clarifications. Thank you.
Thank you very much, Dr. Asidu, for that wonderful presentation in which you have showcased truly the milestones that Ghana has achieved in terms of patient safety in promotion of patient-centered care. We are thrilled by the presentation, and I think it's time now I bring in the audience to engage with you on the insights they've picked from the presentation and what they've learned. How can different economies, both in Africa, but also in Southern Asia, how can they improve patient safety using Ghana as a case study from the examples that you have highlighted? With me, I also have a few questions from the Secretariat, but I think let me first give the chance to the audience to directly engage with you. Please, participants, you have the opportunity right now to engage with Dr. Asiedu using his case study, but also the milestones that Ghana has achieved in terms of promotion of patient care. Please, you can come in. Feel free to come in directly, or you can raise your hand, but it's also okay if you come in directly. Have some 5 minutes that you can use to engage. Members, I'm still waiting for you. Well, I'm also trying to monitor the chat to check whether there are any questions that we can have for Dr. Asiedu for deliberation. So it seems I do not have any questions that I can really have. Maybe Dr. Asiedu, I wanted to hear from you, but of course, let me first thank you for the milestones that Ghana has attained in terms of promotion of patient safety. We've seen that you have incorporated the global patient safety interventions, and that is very good. And also, I was thrilled to note that in Ghana, you have the National Health Insurance Scheme, which is compulsory and national, which at the moment we do not have here in Uganda. But I wanted to hear from you the contribution, how far you are progressing in terms of the budget contributions to the healthcare as per the Abuja Declaration, because here in Uganda, we are still lagging below 10. You noted that you also have challenges to do with budget financing in terms of healthcare, but I'm not seeing a number of milestones you've achieved. How have you managed to achieve that? But also, I want to thank you for the dedicated and continued leadership in terms of healthcare, which is manned by the Minister for Health. It seems to have given you significant results. Doctor, feel free to respond. Doctor, kindly unmute yourself and feel free to respond.
Okay, thank you very much. Yes, I have presented maybe something very nice as far as Ghana is concerned, and I guess we've been part of the quality of care, quality, equity, dignity network, which Uganda, of course, is also there with a number of other 8 additional countries here. So, like I presented, it still has some challenges that that needs to be improved. We do have our national health insurance, which is supposed to be compulsory and also expecting everyone to come on board, but not everybody is on anyway. but that is what we are using to achieve our universal health coverage. In terms of the funding, we haven't also reached the 15% as far as allocation is concerned, but we do work closely with also some of our development partners. The government of Ghana makes some deliberate funding available. We work with our development partners. The CSOs also contribute some quota. The only difficulty is that sometimes some of the additional funding from the various CSOs and their work, and then also the other partners might not necessarily be captured. But if you look closely at putting all these resources together, I can say that possibly we are the 15%. Yes, we are reaching that 15% as far as the Abuja declaration is concerned. But on paper, we're still also playing between 9 and 12%, or sometimes 10% allocation. But I think one of the interesting things is the contribution of the community, which also has to be captured. In fact, we are currently initiating some publication and some research into how much, in terms of the monetary calculation, the community is contributing to the health sector. Because, for example, with some of the pictures I showed, the community take up that responsibility to ensure that they do some specific things within some of the health facilities. And the community scorecard makes it a bit more competitive for the community. So because it's just red, yellow, and green, if you look on the side and you see community A has a lot of greens and your community has red and yellow, the community is charged to do something extra to address those gaps that they were able to identify within their own system. So I think the community contribution and community interventions are the ones that are also helping us as a country to achieve it, because we cannot do it alone as far as the health system is concerned from the provider side. And the minister also opens up more for a lot of engagements. We do have what we call the Health Summit every year, and we bring community, we bring the CSOs, we bring all the providers, and we open up for other ministries, departments, and agencies to make contributions in health, because at the moment, we are saying that health is wealth, and we can only achieve the universal health coverage if we all work together as people of the country. So this is what I can say is helping us and has brought us where we are, whilst we continue to put in some effort to arrive where we want to get to. Over.
Thank you very much, Dr. Ernest, for really that insightful answering. We are thrilled to hear that you are really engaging the community. You are down to the grassroots and you're having the community scorecard, which is very excellent in terms of really engaging communities, in terms of human rights, and in terms of really also empowering communities to engage. That is very awesome, and it sounds very, very exciting. But I noted from your presentation, Doctor, you have in your system, in your healthcare system, you have adopted also traditional and alternative medicines. I saw it in the presentation. Could you kindly highlight to us how you manage to incorporate traditional and contemporary medicine? Because there's been a lot of debate where some health systems discourage traditional medicines, others encourage. So it becomes quite challenging. How are you managing, and how do you find that experience in the health system? Doctor, over to you again. Doctor, this directly relates to patient safety. Come in.
Yes, thank you very much.
Unmute yourself, Doctor.
Yes, can you hear me now? I did.
Doctor can hear you.
Great. So Ghana, as I mentioned, has a pluralistic health system. And we do admit that before orthodox medicine came, there were traditional medicines that people were practicing. And then ultimately, with religion also, imported religion getting into the country, we also got additional ways of managing people. And that's what we call alternative medicine. Now, what is interesting within our system is that Ghana has accepted that traditional and alternative medicine cannot be discounted, for which reason we need to put deliberate systems in place to regulate that space. Because we know that a lot of the community members will ultimately try some traditional health system before they come in contact with the orthodox system. So Ghana has structures in place. We do have what we call the Traditional and Alternative Medicine Practice Council that ensures that all practitioners within the traditional and alternative medicine space are regulated as such. And then also we have the Food and Drugs Authority that also tests the medicines that these providers use. Typically, we have herbal medications and other, medications that are being used. We also have a Center for Plant Medicine Research. That is an agency of the ministry, also resourced to do research into plant medicines. And that is also being used by the practitioners. And then finally, there is an association of the traditional practitioners, which we call the GAFTRAM, the Ghana Association of Traditional Medicine Practitioners, which is also recognized officially by the ministry. They organize their activities from time to time. They invite the ministry to take part. So I think when we open up, that gives the opportunity for us to regularize the way we do our work, and then also to regulate the space and ensure that both the patients, that come to the orthodox setting and also go to the traditional and alternative medicine section of space, get quality service, and they are also safe. We do admit that there are some other institutions, that are also practicing undercover, but there's a system, as far as the regulators are concerned, to put in all the efforts to identify these institutions or the traditional practitioners to get them, regulated by the regulator within the health space. So I would say that these are the things that we are putting in place, but we admit that it is not a perfect system. However, we know that patients will definitely look for other sources of healthcare apart from the orthodox one. So the government has put in all the mechanisms through the Ministry of Health to make sure that we can regulate that space and get the patients to be safe and secured within that environment. Over.
Dr. Ernest, that is awesome. Thank you for that splendid response. And we picked a lot in terms of the controlling of that space, which needs to be done in most parts of Asia, but also Africa as well. Thank you very much. So, members, we still have another opportunity to listen to the next exciting speaker, who happens to be Dr. Gertrude Zika Avotri. Please listen to her profile. It is very exciting. Dr. Gertrude is a technical officer in the Service Delivery Systems unit under the Assistant Regional Directors at the World Health Organization Regional Office for Africa. Dr. Gertrude Zika, a technical advisor in the Service Delivery Systems unit under the Assistant Regional Directors at the World Health Organization Regional Office for Africa. She's a professional nurse and midwife, and she holds a Bachelor of Arts in Nursing with Psychology from the prestigious University of Ghana. She holds a Master's of Science in Nursing Studies from King's College, London. She happens to hold a Master of Science in Public Health from the University of Pretoria, and she's a PhD holder in Health Studies from the University of South Africa. Her focus areas of work necessarily have been healthcare quality assurance, patient safety, infection prevention and control, integrated people-centered health service delivery, and district health system strengthening. Please, she's a member of the inter-country support team for Eastern and Southern Africa countries, and provides country support in her focus areas within the context of universal health coverage and sustainable development goals. Please, having heard and listened to her rich profile, Please, at this juncture, allow me introduce to you that speaker. Please, Dr. Gertrude, you are warmly welcome. And allow me say that the floor is yours. Please take up the platform. Dr. Gertrude, you sound to be muted. Please unmute yourself and speak to us.
Okay, I was trying to unmute. I've now been allowed to unmute. Thank you very much, colleagues. And I must express that we are greatly honored as WHO Afro to be invited to participate in this very important meeting, and also to have the opportunity to further disseminate the Global Patient Safety Action Plan. Next slide, please. Next slide. So this will be my outline for this discussion. And before this slide, I would just have to indicate that the World Health Assembly in May 2019 adopted the resolution on global action on patient safety. And that resolution actually recognized patient safety as a global health priority, and then also established the annual Patient Safety Day on the 17th of September. The same resolution tasked WHO to formulate the Global Patient Safety Action Plan and align it to the strategies that will help us to improve global patient safety interventions and mechanisms. And so, as usual with WHO, we have a laborious process of coming up with such guidance documents. And as you can see on the screen, the process involved doing a lot of scoping and literature review. We had a number of consultations internally and externally that led to the drafting of the document. And after that, we still continued with the consultation with member states. And then in May 2021, the Global Patient Safety Action Plan was adopted. Next slide, please. Next, please. I have discussed this one already. So next slide, please. So the mandate of the action plan is to formulate a global patient safety actions in consultation with member states and all relevant stakeholders. And I'm sure most of you on this call at one point or the other participated in the consultations in the elaboration of this particular document. So the purpose of the action plan is to provide strategic direction for all stakeholders through policy actions, provide a framework within which all of us will implement patient safety actions, align whatever we come up with existing strategies and instruments, and then also provide implementation guides that will help to operationalize the action plan. Next slide, please. So I'm sure most of you have seen the document. It clearly delineates the vision, the mission, and the goals, and then the action plan or WHO further provided the framework for action that clearly outlines a matrix and detailing in each of the strategic objectives, the objectives or the actions that we need to take in order to achieve the strategic objectives. Next slide, please. So I just want to go a little bit in detail regarding the strategic objectives. So we have 7 of them in all. The first one is to help us make zero avoidable harm to patients. And listening to my colleagues, that presented before me, we are all speaking the same language. Our aim is not to harm patients. No healthcare worker goes to work with the objective to harm anybody. So as much as possible, if we can avoid and make it zero harm to patients, we will be glad that we are helping patients. The next strategic objective is to build high reliable health systems and health organizations that protect patients daily from harm. The third one is to put in systems that will assure the safety of every clinical procedure, including from entrance into health facilities, what happens there, and not only in health facilities, but even in the communities. So we must assure safety at all levels of service delivery. The fourth objective, which I'm sure most of you will be very interested in, because we are here discussing issues with patient safety groups, is to engage and empower patients and families to help and support the journey to safer healthcare. I will dilate a little bit on this particular objective going forward. The fifth objective is to make zero avoidable harm to patients a state of the mind and a rule of engagement in the planning and delivery of healthcare everywhere. I always ask my colleagues, when you put on a glove to do a procedure, whose safety do you think about? What is the safety culture in the organization? If the safety culture does not promote patient safety, we will continue to have challenges. So we want to make it a state of mind, and there are key actions that we need to implement to achieve this particular objective. The sixth one is to ensure a constant flow of information and knowledge to drive mitigation of risk, a reduction in levels of avoidable harm, and improvements in the safety of care. And in this area, I must indicate that the Afro region has a lot of work to do here. Access to data and availability of data is a great challenge. We are not able to get the requisite information to even guide most of the decisions that we make in this area. We are grateful that now, with concerted effort from all levels, we may be able to put in systems to generate data that can help us to make effective decisions for patient safety. The seventh objective is to improve our collaboration, our partnerships, so that we can all have synergy in efforts to improve patient safety. So the silos and then the vertical programs that have belabored our continent will have to be looked at so that we can have integrated approaches to the provision of services and safety of care. Next slide, please. So what has happened since the adoption of the Global Patient Safety Action Plan? Since its adoption, we have had two major activities in the Afro region. In the last year, 2021, we held a webinar, a regional webinar for all the 47 member states. And we also had participation from some of the patient groups and associations to disseminate the action plan. The main purpose was to create awareness so that people get to know that there is something like this, that there is a global effort to improve patient safety. So we tried to contextualize the action plan to the regional context. And we agreed at that webinar that it will be necessary for us to determine baseline for patient safety, not only at the regional level, but also at the national level. We need to put in systems to advocate for patient safety and revitalize some of the things that we have abandoned I must indicate that it is not all gloomy. We are aware that pockets of good practices are going on in different countries, but just that documentation has been limited, so we are not able to actually publicize or create the awareness on those good practices. So we want to revitalize those good initiatives and new ones as well. We also agreed at that webinar that we need to develop and implement national guidance documents. And some of the earlier speakers have alluded to this. We need to have national programs on patient safety. It could be embedded in quality of care and then also integrated with infection prevention and control. Every country is different. So whatever suits the country will be what they will do, so long as they are addressing issues of patient safety. Healthcare worker education is an area that was identified during that webinar also that we need to look at seriously, and also facilitate systems for learning experience sharing, and also put in place systems to monitor and evaluate implementation at all levels of service delivery and the implementation in the region. Of course, we need to promote relevant networks, platforms, and associations like yours who are advocating and working seriously in the area of patient safety. Next slide, please. So now I just want to zoom in a little bit on the strategic objective 4, which is really why we are here as patients and family members. Next slide, please. Yes, so this is more or less just highlighting few of the things that WHO is doing in the area of implementing a strategic objective 4, which is on patient and family engagement. So I am, most of you will be aware that there is a patient for patient safety initiative going on at the global level and also at the regional level. The initiative aims to promote active patient involvement in the patient safety program worldwide. And then also the Patient for Patient Safety initiative is building an international network for patients and family members who have experienced preventable harm. And we have patient advocates like those that we have listened to today. And then it also addresses policymakers and healthcare providers measures to improve patient safety as a whole. Next slide. Okay. So I want to zoom in a little bit at the regional level. We are currently developing a regional strategy. We are of the view that the Global Action Plan is a very good detailed document. However, we have some contextualized issues in Africa that were not wholly addressed in the Global Action Plan. So we are in the process of actually gathering data to contextualize the action plan to the regional context. And of course, we will be talking to some of you. We have already talked to some of you, engaged you in this process so that the Afro region, WHO Afro, will have a strategy that will help us to operationalize the Global Patient Safety Action Plan relevant to the issues that the region is encountering. We will also facilitate networks of patient and family associations and groups, and then we'll be engaging some of you to guide us because you have been in this space for a long time. And WHO Afro, we are now more or less in quotes having a concerted approach to implementing the patient safety agenda. So we'll be engaging some of you to guide us and be part of pioneers in this area as we move forward. Next slide, please. I just want to end my presentation by just reminding you of this year's Patient Safety Day. Just as my colleagues indicated, it's on medication safety. And of course, before you take any medicine, you need to know, check and ask And as healthcare workers, before you give, these are the slogans and issues, that key messages that we want you to take forward as we campaign for improvement in medication use in the region. Thank you very much. Over. Next slide. I think I'm done. Hello.
Hello, Doctor. Thank you very much for this exciting presentation in which we have learned really about the developments in terms of patient safety. Personally, I was really touched by the Global Patient Safety Action Plan, and I realized that a lot is moving in this space. And Doctor, we'll have about 5 minutes of discussion with the audience so that they have really an opportunity to engage with you for the developments in this space. I will also have just a few questions for you, probably one or two, to clarify on a few exciting issues that you highlighted. So at this time, it's an opportunity, and I really look forward to your questions, your suggestions. They could be recommendations, or they could be recommendations. Any insights from you members, you are warmly welcome. Let me try to look through the chat and see if there is anyone out there who is trying to engage. So Cecilia, please, you are welcome. You can make your question. Try to unmute yourself and make your question heard. Cecilia, I can't hear you. Cecilia, you can pass over the question through the chat so that I can read it out to Dr. Gertrude.
May I go ahead? Hi, everybody. My name is Njahera Wangari. I'm currently doing my PhD at University of Pretoria, looking at the intersections of healthcare providers training and disability, more specifically muscular dystrophy for myself. And first of all, I just wanted to echo just those sentiments that no healthcare provider goes into the workplace wanting to help a patient. And having been in patient advocacy and someone with muscular dystrophy myself, I feel like sometimes you rarely see the other side of the provider, the healthcare provider, and we might get stuck even in our advocacy at focusing on that alone, rather than looking for solutions together with the people who are actually supporting our healthcare. So I really just enjoyed that contribution, and yeah, thank you for that.
It's very exciting, and we're happy to hear that. Yes, Priska, I can see your hand up. Please go ahead.
Good morning, everybody. My name is Priska Githuka from Nairobi, Kenya. I'm a chair lady of the Cancer Survivors Association of Kenya and a director of Pink Hearts Cancer Support Foundation. I would like to first of all take the opportunity to thank every presenter for their presentation, very insightful, and even for the organizers of this very good conference. My question is on the call to action, no, check and ask, speaking from the patient's perspective. As patients, we believe what the doctors tell us. So we don't have the knowledge. So if you tell me to go and take paracetamol, that is what I'm going to take. And maybe paracetamol is not what I needed. I needed something else. So for me, maybe I would like to hear from you or any other person within the audience. How do we educate patients for them to be more empowered so that they are able to really ask questions with regards to their treatment plan? And again, I'm speaking this from the angle of a cancer patient, where you're being treated through IV. If it's chemo you're getting, you don't know the doses, so you take what the doctor is telling you. So how do we empower patients, specifically in this case, like cancer patients, to be able to know that this is the way it should be? What kind of things should we do? Thank you.
Dr. Gertrude to respond before I get back to Penduka. Dr. kindly respond.
Okay, thank you very much. I'm happy that the question was directed to all of us. In the sense that, okay, this is a very important area. If I do not know, how do you expect me to know? Which presupposes that we need to identify strategies that can actually improve the knowledge of patients. I always say that there are several ways to kill a cat. One strategy for a patient group or a particular patient may not be the same for others. Previously, I did some work in this area, especially regarding the education of mothers during antenatal session. Then I will just share experience to put what is happening now in our context, our region in context. You have a healthcare worker, often maybe a community health nurse. We all know their background, standing in front of a group of mothers at the antenatal clinic and actually talking probably in English. People are there in different trimesters, and then it enters one ear and it goes into the leaves through the other. So I asked, the focused antenatal care mechanisms that were introduced was an approach to have an individual one-on-one speak in a language that the person understands. And this is just to put it in the context for all other aspects of patient education. What is the objective of this education? What do we want the patient to understand based on the engagement that we are having? We need to come up with a structured approach on the processes of going through this. And whether it is a group or whether it's on individual basis, there's always a systematic way of doing this. And there are a number of guidance documents that WHO has produced. And I'm hoping that as we go forward in disseminating and training our people who do the education, we'll be able to improve. I'll just end it here for now. Yeah.
Thank you very much, Doctor, for that elaborate response. I think we've picked really value from it. We've learned that we need to refer to the WHO reference documents, but of course we need to speak the language that the patient understands. That's how you wrap it up. So there is also another question from Sisi Penduka. Please, you can come in.
Thank you very much. And thank you, Dr. Gertrude, for your presentation. I just wanted to understand from the WHO perspective whether they have any initiatives or recommendations aligned to building a culture of safety. Can you hear me?
Yes, I can hear you.
Okay, so my question has to do with promoting a culture of safety. I think the comment from the first speaker, the question they asked about always seeing patients complaining about the danger they've been put by healthcare professionals being the picture that we often focus on, and not so much about the healthcare providers who are actually, whose first mandate is actually to keep us safe. So I'd like to know whether there have been any recommendations around making healthcare professionals more comfortable about disclosing medication errors or medical errors or treatment errors, so that the more we know, the more we are better able to have interventions to promote patient safety. My interest in this comes from my involvement with regulating pharmacy practice in Zimbabwe and just trying to find a framework where we can have healthcare providers be more comfortable disclosing errors so we can learn from them. Thank you.
Okay, am I to respond or I should wait for additional questions? Can I respond to this one?
Go ahead.
Oh, okay. The culture of safety and the culture of reporting errors. I always say that in our context, this is an area that we have a big challenge because in our community, in our culture, and then the culture over the years from all that we have read and have experienced, the issue of blame is huge. And I have always have the conviction that it's not going to take one event for this to go away. When I did some work some time ago or in Ghana, I was saying that, okay, can we start with anonymous reporting system? It didn't even fly from wherever we had the discussion. People are just not comfortable reporting because of the implications. Until we get to the stage where people feel free, are confident, and know that when they even report this, they will be supported. We will still have a long way to institute the system, but that doesn't mean we shouldn't start. We have pockets of countries that have started putting this mechanism in place. They are providing some legal leeway for healthcare workers so that they are comfortable to report. They are not there yet, but they have started the process. And my sister, I would like to also indicate that there are theories, there are guidelines, but implementation will have to be context specific. And so as we have started the process of having a systematic approach to implementation of patient safety interventions in the region, this is an area that we have captured that we'll have to deliberate more on, identify strategies that we can use to support countries and to improve on what is existing at the moment. I will stop here for now. Thank you.
Thank you very much, Doctor. And thank you very much, Doctor, for the responses. And we are very, very happy. And we've learned really a lot from your presentation. Thanks for preparing, but also presenting and responding to the questions. So, members, at this time, we are going to have another presenter who will take us through access to quality and affordable health care for vulnerable populations through low-cost insurance platforms tailored to patients' needs. So the presenter that I'm going to showcase before you has a rich profile. Allow me to go through her profile. So she happens to be Riolinde Baker from Pharma Access. Riolinde Baker leads the business expansion of safe care in Africa and Asia. Safe Care is part of the Pharma Access Group, an international not-for-profit organization dedicated to the strengthening of health systems in sub-Saharan Africa. The safe care approach is based on internationally acknowledged quality standards and dissects the improved process of healthcare providers in surveyable measurable steps. The methodology has been adopted by public and private partners in over 15 African countries. Riolinde has a background in health sciences, innovation in healthcare, innovation in healthcare has been common thread throughout her career. I'll tell you that before joining Pharma Access in 2021, she worked in healthcare procurement, microinsurance, and healthcare innovation in Africa and Asia for Dutch insurer Achemia and TNO, a Dutch Innovation and Health Institute. I think you've heard and listened to the rich background of Riolinde. So at this time, members, allow me bring you the speaker. Please, Madame Riolinde, the floor is yours.
Yes, thank you so much for the nice introduction and the nice words. Good day, everyone. It's great to be here with you today and to be part of this important meeting. And I want to present to you the important topic of access to quality and affordable healthcare from our experience with you in the countries we work. Can you please go to the next slide? Yeah, so I want to talk with you about access to quality care for vulnerable populations tailored to the patient needs. Next slide, please. So just to give you a little bit more background about PharmAccess, my organization, we are an international NGO making inclusive health markets work, using digital technology and stimulating public-private partnerships, ensuring quality of care for everyone, including vulnerable populations. Our head office is in Amsterdam, in the Netherlands, and we have 4 offices for core countries in Ghana, Nigeria, Kenya, and Tanzania. And we are now also expanding our work and especially SafeCare, our quality improvement program that I want to share with you today in countries like Malawi, Zambia, Madagascar, but even in Asia, in countries like India. Next slide, please. So the work that we do as PharmAccess is really about making inclusive health markets work. So it's really about system change, and that was also mentioned by the previous speakers. So from what we see is that access to insurance is key. It starts with insurance to increase access to care, but that's not the only part. It's not only about demand side and health financing, it's also making sure that there is quality health care so that more patients are likely to trust health services and even are willing and able to prepay for insurance. And it's important for financial sustainability of insurance scheme. So all elements are coming together, and it's really about creating trust in the healthcare ecosystem together with governments, together with healthcare professionals and with partners. So that's the work that we do, also with governments supporting on the strategy for universal health coverage. Next slide, please. So this is one example from Ghana. I think it's really about the leadership also at the national level to work on it as stakeholders together, creating value. And the digitization and data, it's a great way to even, fast track the challenges we have, to have insight in what's happening, to monitor the uptake of insurance and quality healthcare. Next slide, please. Next slide, please. So today I want to deep dive more in quality healthcare. Can we go to the next slide, please? Yeah, so for quality healthcare, it's really it's more about there are more people dying from poor quality healthcare than lack of access to health services. So to improve quality healthcare, that's really key in the universal health coverage agenda. So you can see it on this picture. So this is the global challenge we face. Poor quality of care causes more deaths than lack of access to care. So there's really an urgency to come together to see how we can close that gap. Next slide, please. Yeah, so I think when you look at a patient perspective, there are many examples from preventable deaths. And quality, it's about medicines, it's about infection prevention, It's about lack of triaging emergencies. So severely ill patients need to receive antibiotics within the hour, otherwise mortality increases. And this is really emphasizes the need of standards, standards and at the national level, so that there is the standards that are in place and health facilities know where they need to comply with. Next slide, please. So what we see is in the uphill task of improving quality with limited resources, that there are many challenges. So healthcare providers often struggle how to improve quality due to lack of knowledge, time, and guidance. And most of the time, quality is seen as extra work after the close of business. And there are several challenges indeed. It's about existing quality approaches are often too expensive and they are not recognized by the local authorities. Only a few health facilities participate, the happy few, but then there's no benchmarking on a national level. There's no overview, as a baseline when it comes to quality healthcare. And most of the time, the standards are not achievable. So it's more like a burden than that it's really possible to integrate it in a workflow within the health facility. Next slide, please. So what we did in 2009 is, together with GCI and COSASA, we developed a safeguard setting and new inclusive standards. So it's a really tailored approach across resource-restricted contexts. It inspires to improve by focusing on progression. So it's really every health facility in a city or a rural area can just step in. These are international accredited standards. And we now have more than 10 years of experience of implementation across health systems, from basic health systems to referral systems, that showed that it's work and it's feasible to implement it. And yeah, that was also mentioned by the previous speaker in Ghana, for example, how the standards can be embedded in the healthcare ecosystem. I think that is a really great example. Next slide, please. So this is really to give a little bit more background that what are the safeguard standards then? It's covering a full range of medical to non-medical aspects of care. So it's really about the business performance and the clinical performance. And it's really a holistic approach. So it goes through the whole health facility. All elements are in there. And with that insight, the health facility as a team can work on closing the gaps and making possible that the patient will experience a seamless process. It's also about patient rights, the privacy of patients. And when the health facility starts working on those elements, we see we have a lot of examples and practices in different countries that patients experience a seamless process, that feel respected. And also from the health facilities, more patients are likely to come in. So it's really patients are sharing it within their neighborhoods and within the community. And because of this, they feel well treated, and they receive good quality healthcare. Next slide, please. So it's really about an ecosystem approach and engagement at 3 levels. Of course, it starts with the healthcare professionals to cultivate a team culture of quality improvement. And now more and more, we also work with licensing partners, because we are not going to double ourselves in all countries. But for example, what was mentioned by the previous speaker, Christian Health Association in Ghana is one of our license partners. They implemented Safecare within their network, and also it is embedded in their in their approach. But also the recognition at the national level from governments and public partners is extremely important to incentivize quality healthcare. So by the National Health Insurance Fund, that if health facilities are part of Safecare and they can show the progress they made, are more likely to get an insurance contract or can have a contract by the NHIF. And of course, it's really important to contextualize quality healthcare and institutionalization of quality healthcare. So what we also do in countries we now work in is also to adopt and adapt safeguard in a national level in the national quality management framework. So then it's more, having a national certificate of quality healthcare available. Next slide, please. So how does it work in practice? It's really an integrated assessment and improvement program. It is online and offline tools. It starts with a quality assessment as a baseline. So that gives insights to the health facility, where are the gaps. And then they will receive a tailored quality improvement plan that guides them through the journey to improve on a certain criteria. It's all digitized, and the support we give is through an online quality platform, but also through in-person guidance and support. Next slide, please. So our approach is really about stepwise quality improvement to make it sustainable and achievable. So it starts with level 1 up to level 5. And when the assessment is conducted, the outcome is that you are in a health facility in level 1, or you are in health facility in level 2. And in level 1, it's likely that the quality of the service is likely to fluctuate, and there is a risk of unsafe situations. And so there's really an urgency to work on the criteria when it comes to clinical performance and business performance. And at the end, at level 5, you are really an outstanding, high-quality healthcare facility. So it's really about stepwise improvements combined with safeguard certificates. Next slide, please. We work with an online quality platform to support healthcare providers, so they have it on the smartphone with guidance and motivation, how they can work on the criteria. All the guidelines from the World Health Organization, national guidelines are in there. So we see that it's really about empowerment at the health facility level, that professionals know what to do and where to work on in achievable steps. And on the other hand, on a high level, we have the quality platform for stakeholders, for example, for the Ministry of Health or the network partner, that gives insights at the regional level what is happening, and that is also really helpful for research allocation, what is needed in what place, and where we need to prioritize when it comes to close the gaps. Next slide, please. Yeah, so this is really briefly to give you a bit more understanding the impact and numbers. So this is from last year. So we have 2,026 facilities across several countries, and 60% of the patients are women and children. And most of the patients are part of the low or very low income groups. I think that's important to mention. And what we see is that 79% of the facilities indeed improve their quality of care score over time. Next slide, please. Yeah, so of course, I have many examples from the countries we work with, but I really want to show you the example of Zanzibar. Zanzibar, we have a partnership at the national level with the Ministry of Health and also the Ministry of Finance. It's really about making the shift from free to sustainable financial healthcare. Next slide. So at Zanzibar, they have really a challenge how we can move towards a sustainable health system where the strongest shoulders carry the heaviest health burden. How to be ready for the future, how also to have a strategy in place for universal health coverage. Next slide, please. Yeah, so what we did is that this program and partnerships is really consist of 3 pillars of change. It's really about introducing a quality management and an improvement tool. So it's about achievable and sustainable steps. So the SafeCare methodology was contextualized to the Zanzibar context together and now implemented. It's also about a digital approach with real-time quality dashboards. So with that, it reduced 50% of the workload of the professionals. And besides the quality supply part, it was also really about the demand side. We are looking at the finance strategy to introduce social health insurance for the poor, that clear sustainable finance strategy, and also to start with a health trust fund. So it's the combination of both that needs to be in place, and it's really about introducing the healthcare ecosystem approach. Next slide, please. So what were the key success factors? Was really about, there was proactive ownership of the Zanzibar government and leadership. There was joint planning and implementation. There was a quality union established by the Ministry of Health. And there was really a strong partnership. Of course, it's really about building trust, creating value, but also to have clear and formalized agreement on what is the way forward and have a clear roadmap in place. Next slide, please. So what we achieved so far is that we really strengthened the capacity of the council health management teams. So we really did capacity building in training the assessors. So they are able to perform the assessment at the health facilities. It was really about introducing a digitized system, so no more manual paperwork. So it was really into transition and a new way of working. And it was also about quality of care at the health facility level. In 2020, we started, all 102 facilities started at level 1. And at the second assessment, 1 year later, we see that all facilities are now stepping up to level 2 and 3. And in today, we are still continuing the journey to make sure that all facilities will improve even to level 3, 4, and 5. So this is just to show you the journey with Zanzibar, and of course we have also examples from other journeys. This is for today, and I think moving forward we see that more. The governments are working on a national quality management framework and have a need for tailored quality assurance. So we are now expanding our approach to more countries, and the empowerment of the patient in that picture is really important. So that is also in our scope to see how we can use this information to empower patients, that they know where to go to when they look for quality healthcare, and bring that transparency also to patients. So thank you so much for this opportunity today. And please, if you have any questions, you can ask them now or contact me by email. Thank you.
Thank you very much, Madam Yerolinde Baker, for the good work you are doing in the Afro region, but also in other parts of the world. We noted with concern and we were very excited about the presentation. Personally, I was impressed with the work you are doing in Zanzibar amidst the challenges the country is faced with. So, Madam Yerolinde will not take any questions at this time. We thought it would be ideal for us to first go through the entire session. Then after the presentation from Dr. Janet Biaruhanga, which will bring us to the climax. Of course, we shall have again another session from Madam Catherine Skippers from the Max Foundation. And after that, we shall be taking in all the questions to the different speakers. We kindly ask you to keep around, stay with us, so that we are able to answer these questions from the audience. So at this time, members, allow me to introduce our subsequent speaker, who happens to be Dr. Janet Biaruhanga. Dr. Janet Biaruhanga has a rich profile. I should say that she heads the Health Unit, African Union Development Agency, call it NEPAD. Dr. Janet Biaruhanga is a qualified medical doctor and a public health expert that obtained her postgraduate diploma in public health research from the prestigious University of Edinburgh and has over 14 years of experience in international development with special focus in human and social sectors. She has served as a health policy officer at the African Union Commission since 2007, where she provided technical leadership and oversight in development and delivery of key strategic continental policy frameworks, programs, and initiatives geared towards strengthening the continent's health care delivery system, food security and nutrition, and promoting the social well-being and rights of women and children. Dr. Byaranga, since 1st September 2017, joined the African Union Development Agency as a senior program officer, health. She's in charge of coordinating and facilitating development and implementation of policies on health and medical products, and ensuring their alignment with industrial development, trade, science, technology, and innovation policies in advancement of the African Union's African Health Strategy and the Pharmaceutical Manufacturing Plan for Africa. Please, I hope you've heard and listened to the rich profile. So at this time, allow me to officially invite Dr. Janet to take up the floor. Please, Dr. Janet, the floor is yours, and we are thrilled and happy to hear from you. You are welcome. Doctor, kindly unmute yourself so that you can speak to us. We are really waiting.
Can you hear me now?
Please, I can hear you loud and clear. You are welcome.
Thank you so much, Program Director, and thank you for the kind words of introduction about myself and my institution, the African Union Development Agency, NEPAD. And I'm happy to be associated with this meeting. I've been listening in and really excited to learn from this platform. It's my first time, and I'm really thrilled to be a part of this process, and hopefully my presentation also will bring in a new sort of dynamic to the conversation. So the title of my PowerPoint presentation is Project Benjamin. It's a pilot project that we are trying to roll out starting September next month, to unveil the strength of community healthcare workforce, one health post at a time. Next slide, please. Is somebody manning the slides for me, or am I supposed to do it myself?
Doctor is doing it.
Thank you so much. Next slide, please. So as you will notice, this is mainly about primary health care system strengthening efforts that the African Union Development Agency is trying to engage in. So from the definition that was adopted 44 years ago about primary health care, we know that this is the essential healthcare that is based on practical, scientifically sound, socially acceptable methods and technology, when it's made universally accessible to individuals and families in the community through their full participation at a cost that the community and the country can afford to maintain at every stage of their development in the spirit of self-reliance. So this is a very wordy definition, but the key points here we get is that in primary health care, there needs to be acceptability, accessibility, participation of the community in deciding what their health is going to look like, and the the other key area is the fact that it should be affordable and create some sort of self-reliance. Next slide, please. So in our project, the AUDA will be supporting member states' efforts to strengthen the resilience of their health system through improvements in community healthcare workforce capability. Next slide, please. So what is the problem that we're going to be solving with this small project? There are 4 key gap areas that we're seeking to address with our proposed project. Number 1 is the inadequacy in numbers and quality of community healthcare workers in the countries where we're going to implement this project. The gaps in knowledge, attitude, and behavior about how to prevent common health problems in the countries and communities that we're going to be serving. The poor access to medical products and other commodities, and the low proximity to health infrastructure for the delivery of basic services. Our project is going to be piloted at first in 5 countries, and you will understand the reasons to why these 5 countries were selected, because they have a relatively weak health care system due to various reasons. So our 5 countries are Chad, Central African Republic, Burundi, Lesotho, and South Sudan. Next slide, please. There are 3 pillars of focus that we're going to be, our project is going to be focusing on. Number 1 is training and upskilling of the community healthcare workers. And here we will build on the existing numbers and use the existing healthcare workforce to recruit more, deploy more, and train them. Pillar number 2 will focus on the communities themselves, educating them and making them aware of the common health problems in their communities and how to prevent and control them. Pillar number 3 will focus on identifying key areas of infrastructure, both digital and physical infrastructure, to improve. Our guiding principles are going to be the 8 A's and the 3 C's of primary health care: appropriateness, adequacy, accountability, availability, accessibility, acceptability, affordability, accessibility, completeness, continuity, and comprehensiveness. I think there's no need to go deep into those. Pillar number 1, as I said, we'll focus on upscaling and training community healthcare workers in these 6 areas: delivery of diagnostics and treatments and other clinical services, how the community healthcare workers and volunteers can assist with the appropriate utilization of health services and making proper referrals, providing health education and behavior change motivation to community members, training them on how to collect data and better recording systems for the patients, mechanisms to build relationships between the health service and the communities, and then providing how to better provide social support. Then the pillar on education to the communities, this will be aimed at empowering the marginalized groups and ensuring their participation in driving their own health. And the main focus of our engagement and awareness raising campaigns will be on topical issues such as maternal, child, and men's health, communicable and non-communicable diseases, adolescent health, palliative care, physical activity, first aid, and so on. Next slide, please. The last pillar, which is pillar number 3, will be focusing. Can you go to the next slide? Next slide, please. Next slide. Program Director, are you hearing me? Yeah, pillar number 3 will focus on improving infrastructure for delivery of primary healthcare commodities and services. In here, we will try with the member states that have been selected to identify, to assess, and to support operations of brownfield ICT and or physical infrastructure that can be used to improve the delivery of last mile health care services. Next slide. Our role at the African Union Development Agency, NEPAD, will be the coordination of the various stakeholders. So we'll have activities at the regional level, which is literally at the AUDA level, and also at the national level. So at the regional level, we will be convening and mapping stakeholders. We will be identifying which partners are going to provide some catalytic funding and technical expertise. We will identify and commission experts from the various partner agencies to support the countries in drafting the execution plans, implementing the execution plans, trying collating data and getting reports, convening the continental level and country level workshops, and also communication and reporting on the project to our funders and sponsors. What ultimately we would like to see is the increase in the proportion of community healthcare workers to the starting point for each country, and then an increase in the number of the beneficiaries of the education campaigns on knowledge, attitude, and practice that we'll have assessed at the beginning of our project, and then increase in the number of brownfield community health infrastructure projects that will have been initiated and will be operational. I think this will mark the end of my presentation, very brief, but just to say that the African Union Development Agency will continue to leverage on our mandate to ensure that our member states strengthen their policies and practices and are able to achieve the proper investments that are required to strengthen and build resilient healthcare systems, particularly with focus on primary health care. Thank you very much again for the opportunity and looking forward to the questions. Thank you. Back to you, Program Director. Thank you.
Thank you very much, Dr. Janet, for this insightful presentation. So I've noted in the chat, and there is some slight change. We are going to take in a few questions to Dr. Gertrude so that she's able to respond. Please, the audience, you are welcome. In case of any questions, feel free to engage Dr. Gertrude. Okay, Dr. Janet and your Riolinda Baker from Farmer Access so that they are able to respond to us. Please, I invite your questions. I'm also monitoring the chat. Please, Nimeta, I've noticed your hand. Please, you can have your question to the audience.
Hi, yes, sorry, thank you so much. I'm Dr. Nimita and I work as a portfolio lead for Swasti, an organization non-profit based in India. And Rolinda, thank you so much for your presentation. And I had some questions about the quality of care in particular, because you spoke about the different mechanisms in which quality can be provided. But at the same time, what makes me curious is how do you balance competing perspectives and diverse levels of accountability in healthcare systems, owing to a very diverse workforce. And in my experience and my research, I've come across quality of maternal care, which is extremely varied and diverse based on multiple factors such as autonomy, access barriers. So my question here is, how do you navigate through those differences and set particular standards? Thank you.
Dr. kindly respond. Dr. Riolinda, kindly respond.
Yes, of course. Thank you so much for sharing that question. Yeah, I understand what you're meaning, and of course, it's several factors that come together. And it's really about a growth model. It's a step-by-step approach. So I think the standards are really, I mean, they're in place. There are international standards, and of course, every country is different, but they are international standards that are based on elements that are, similar to if it's India or Ghana. That's really universal standards. But when it comes to the implementation, it's really needed to contextualize what is needed in specific context. So we have the proof of concept that the standards and assessment and approach is applicable in India, but also in Ghana. But when it comes to empowerment of patients and creating value in a healthcare ecosystem approach, it's really about the culture, building partnerships, and also ownership. So it's also really about the soft skills that can make it happen. And indeed, it is complex, but we have seen in Kenya and also in Ghana, if we work on all the levels, so the facility level, the network level, but also the national level, it's possible to integrate it in a national quality framework and to incentivize quality healthcare together with the regulators. But to institutionalize quality healthcare, it's a journey that takes 5 to 10 years from our experience. So it's really a step-by-step approach. And I really believe that together we can do that. So, but thanks for sharing your question, and also happy to connect directly if you want more information or we can exchange more. Thank you.
Dr. Baker, thank you for answering, but also we are glad for the question as well. Doctor, I wanted to kindly hear from you. How are you managing to improve the health ecosystem in the different countries where you are working amidst the data challenges as noted from WHO Africa? You can come in. Dr. Baker, you can come in.
Yes, of course. It's really about, it's a team effort. So it's really about building coalitions on a national level. So, for example, in Kenya, you have the Kenya KQMS, the Kenya Quality Management Framework, that was developed at the national level, and the safeguard standards were used as an example and were adopted and adapted in a large stakeholder group. And as Pharmaxis being a quality expert, we gave technical assistance also in that journey and in that process. And now the safeguard standards, you have the Kenyan KNOS, the Kenyan National Accreditation System and Board. So the safeguard standards are the few standards in Kenya that are complying with the national accreditation body. And in that sense, a health facility in Kenya, they can choose to comply to KQMS, but they can also choose safeguard. And if they step into safeguard, then they comply with the national quality management system. And with that, the safeguard certificate is also recognized by the National Health Insurance Fund of Kenya. So in that sense, it's not only about working quality improvement, but there is also an incentive for health facilities because of course, they want to run their health facility as a business. And if they are likely to get contracted by insurance or by the National Health Insurance Fund, they get more revenue, and then they can grow more patients with them. But from the patient side, we also see examples. I have seen it in Kenya, but also in other countries, that the patients that are within the health facilities, they feel better treated. They experience a seamless process, so they bring in other patients. So it works from both sides, and it's really to the ecosystem approach. How we do it is really to engage at all the levels, the health facility level, the level, and the national and the national level. But we do that together with partners. Thank you.
Thank you very much for responding, Dr. Baker. Dr. Janet, your presentation was awesome. Thank you for preparing, presenting, but also being with us for the entire day. We are thrilled and very excited. We are very happy with your presentation. And once again, it's an honor for us really to engage you. So the audience, we can take in 2 questions to Dr. Janet, and she can clarify to us, share with us before you can proceed. Please, you are welcome. Please, Abang, you can come in and have your question. Kindly unmute yourself, Abang, and speak to us. Dr. Janet is waiting for you. Yes, are you able to speak to us? Okay. So members, allow me to introduce to you another presenter who happens to be Catherine Skippers from the Max Foundation. She'll be taking us through a presentation supporting medicine supply chain and building global networks of health caregivers to establish people-centered health services to improve the quality of services and patient safety.
Thank you for the introduction. I just want to do a quick sound check. Can you hear me?
Hold on. Yes, I can hear you. Kindly go ahead.
Thank you so much. We can go to the first slide. Again, thank you for the introduction. My name is Kathy. I'm with the Max Foundation. I'm actually based in South Africa, and I am from South Africa, so everything within this region is very personal to me. A little bit of overview of what the Max Foundation is. As like many of you on this call as patient organizations, this started with a story of a patient, and in this case, it was Max Riveralo that was diagnosed at a very young age with a very rare disease called chronic myeloid leukemia. His family at the time lived in Argentina, and their treatment options were very limited. As we see with so many of our cases, the family had to pretty much uproot themselves and move to the US to look for a bone marrow donor, which at that stage was the only treatment available for Max. Unfortunately, Max never received the right donor, and he passed away at the age of 17. But this did not prevent the family from taking action, and they started with a small group of volunteers in the year of 1997, starting an organization to help educate and create awareness with other families within Latin America about disease education, awareness of disease, and resource options and referrals. So that relates to so many of the patient organizations that we see in our region today that starts with a trigger event like this. Here we are 25 years later as a global organization, and we're approximately 70 team members strong based across the world, working towards, you can give us the next slide, please. Working towards our mission, which is to accelerate health equity. We do this by delivering medication, technology, and services to patients facing cancer specifically, but recently we've also broadened out to other critical illnesses, and we focus our energy on those that no one else is helping. We understand that within the current structures, it does take a lot of time to bring a product that has been placed in the market into the developing regions. We have to consider product registration, etc. So in that case, we really work towards filling a gap where we understand there is a gap, is bridging that gap until a more sustainable solution or long-term solution can be found. So through that, our vision is a world where all people can access high-impact medicines, where geography is not destiny, and where everyone can strive for health with dignity and hope. And the part that stands out for me specifically within our vision always is that it doesn't matter where you're from, you should always have access to the same treatment and care that patients in developing countries have. I can see I'm being rushed on my slides a little bit, but we'll take it. Thank you. So everything we do revolves around the patient. The patient is at the middle of it all. We identify, or we work in specific disease areas, as I said. So we're not a broad organization in terms of disease coverage, but really specialized in rare diseases and oncology. We work with a network of healthcare providers. These are physicians, clinicians identified in country that goes into an agreement with us to say they have patients that would need the medications we have available for donation in our portfolio, that they would commit to prescribing the treatment as it appears on the product label. And then they also work with us to enroll these patients in access programs, to ensure that there is a transfer of product through supply chain into clinic, and working with our pharmacy partners to ensure dispensing to point of patients. We don't only work with a network of physicians and pharmacists and our pathologists, but we also work in country with patient organizations. Specifically, our MAX team is based in some of these countries. We have members there that really work on ground level to understand the cultural nuances that might prevent patients from, first of all, seeking treatment, using the treatment correctly, and then how that could affect the outcomes. The treatments available are donated products. These are all treatments that are FDA approved and also approved in the European countries. However, in most cases, as we know in Africa specifically, that and in other low and middle income countries, that project registration and product availability is very low. So these are not trial drugs. It is not therapies that are not recognized within the standard protocols. These are actually treatments that have been registered and is currently being prescribed in our more developed countries. And all this we do through our own shipping and logistics network as well. We have a third party that manages this on our behalf, but we have oversight of inventory from warehouse level to point of dispensing to patient. And just to summarize that, we do that through a software that was developed in-house and is called PATS, which stands for Patient Assistant Tracking System. And again, I'm speaking to the patient groups or the smaller groups within this call, is many of you also sit with data that you collect, and we also started with collecting data many, many years ago. Originally, this was data sets that sat in Excel. Obviously, as the world progressed and cybersecurity and the need for digitization of medical records, the software was developed by our in-house software developers. That is now a whole department that complies with all the global regulations on patient safety and health record keeping. So PATS is the thing that brings it all together, in which we can actually track patient data from enrollment through receiving of product and measuring the patient outcomes. We do not share this with third parties. This is for our own use and for oversight by our doctors, because we also understand that in the region, it's very difficult to have access to digital health records. So in a way, for a patient that is enrolled into our programs, the physician has oversight to go and manage dosage, see when the patient was last dispensed, and also include recently test results so that they have that on hand. You can go to the next slide. So pretty much it's a grassroots organization that works specifically around the patient and the patient need, again, considering what the country status is and what is available. I will just say on the previous slide as well, the one thing we really work on as well is in terms of diagnostics and monitoring support. I think, honestly, if we look at patient safety, it starts, first of all, with ensuring that patients have the correct diagnosis. If we don't have the correct diagnosis and we are prescribing, we know the outcome of that is either overtreating or toxicity, and that is also something that we're really aware of. So really supporting diagnostics and monitoring within all our programs so that we know that we have the right patient on the right treatment, receiving the right dosages. In terms of our management of the donated product, so we are very fortunate to have companies that provide us with donated treatment, which we then forward as a donation to our patients through the enrollment of the physicians. So we have our manufacturers that manufacture the product and they ship the drug to us as a gift in kind. And these are stored in warehouses in Switzerland and the US that have been approved by Pharmacare, not Pharmacare, but Swiss Pharma. And once we have the product ready for shipment into country, we've identified the patient volume, we've got an inventory oversight. We work with the partner sites or institutions to get the import documents ready, specifically the tax waivers and levy waivers. For those of you working in medicines access will understand what I say, that the biggest challenge sometimes in access is not having the treatment, it's actually getting it through a customs process. And the bureaucracy of getting a product through a donation or at a low cost into countries sometimes are biggest barriers in medicine and healthcare access. And then once we get it cleared through the customs process, it's obviously ensuring that it's delivered to the site. All our products are shipped with temperature loggers. So once it receives the institution, that data is uploaded into a central database. And if there's any temperature deviations throughout the supply chain, we would flag the site to either quarantine, destroy, and if it's fine for use, then we give them the go-ahead to dispense to patients. Once it receives at the institution, it becomes the institution becomes the owner of the donated product, with the agreement that they will give this to the right patients as enrolled into the programs, and therefore they track it up to the level of dispensing. Next slide. Again, as I've said, we do this all through a digitized system called PATS, which was developed in-house many years ago, and that's been now taken as an app as well, so that everybody can have oversight of the movement of product, patients, etc., in a safe environment. We also understand that the time, one of the previous speakers and the questions was regarding how do we note errors and how do we report faults and how do we manage patient safety. And that's also one of the things that we require reporting on in an agreement with our clinicians, is that all adverse events needs to be reported within 24 hours. And we also adhere to that, is if we learn of any adverse events or any disruption in supply or anything to do with safety, we report it to the relevant safety desks in country within the indicated 24 hours. And the app would allow for a physician that is in a clinic to log that AE and upload as soon as they are again connected to the internet. Next slide, please. So what does that look like for us in this region, specifically where I am leading the team? Is we are currently, as we sit here today, providing treatment, donated treatment to 8,000 patients. 8,000 patients today within this region in 29 countries are getting access to high quality treatment that has been through a QA process, shipped into country and have it in hand. This is treatment they would not have had in any other way. So we work in 38 clinics with 68 physicians in this network in this region only. We have 10 compounds, in other words, 10 treatments or therapies. Most of those are within the oncology and hematology, and we have another compound for cardiology specifically, and these are provided through the donor companies or 5 manufacturers at this stage. And then we have our shipping and logistics partner, which is direct shipment to the hospitals and clinics. Thank you. The next slide. So this was part of the patient services. Again, also, as I've said, in terms of what we do in diagnostics is following up and ensuring that there is the right diagnostic support and monitoring, because that applies to everything we do, is ensuring the right patient gets the right treatment. And what does the impact look like for us? Well, after gathering all this data, after all these years that we've been busy, is that we can now publish this and we can say this, that a patient diagnosed with CML in a developing country has the same life expectancy and outcome as a patient residing in a developed country. So the barrier was eradicated through a donation program. And access to treatment, we honestly believe, is access to life. It is a holistic approach. I've heard so many of the speakers speak today of so many aspects, and I can 100% agree to everything in saying that it is such a complex system and we need to address so many areas, which we as an organization also value and try to create impact in. I do think there is definitely a way forward in saying this. everybody is working towards improving patient outcomes. We all strive to have patients have access to the right treatment at the right time in a healthcare system that is reliable and provides quality care. So for me, moving forward as well, is to see how as organizations and as entities, we can always work together instead of duplicating resources, rather how do we do what we do well. I have to say on this note as well is that as an organization, we also understand that donations are not the most sustainable way forward. So in some of the countries we've worked in for several years, where we are aware generics become available, is helping the ministries of health transition that level of care into a locally owned program, if I can put it in those words, where they require or they purchase the generics, and that we can then phase out the donation aspect. But again, there's so many areas in that needs to be developed, as you might all know, in terms of the patient education, the health system strengthening, procurement, etc. So that's another area and another discussion that we would have to go into. So next slide, please. So this is my last one, is just thank you so much to the organizations for bringing all these like-minded, passionate people together. And if you have any questions for me, or you would like to learn more about the Max Foundation, you're welcome to reach me at the email address on your screen. Thank you very much.
Thank you very much, Katharina Skippers from the Max Foundation, for this exciting presentation in which we really learned a lot. So members, you can really have your questions to Madam Katharina Skippers so that she can be able to respond to you briefly and concisely. Let me try to go through the chat and identify any possible questions in there. I'm not able to identify any question. Let me try to look at participants themselves. I'm not seeing any hands up. It seems the presentation was really answering all our questions. Because I haven't identified any questions, maybe I should really thank you for preparing, presenting to us, but also sparing time to attend. So members, I can say that it's been good since morning. I think it's high time we had our lunch, then be ready for the subsequent sessions. So members, feel free to have at least a snack for your lunch. Thank you. In the meantime, we are going to be running the registration link for the room meeting so that members are able to register. This is going to take us about 10 minutes. Then we shall be returning in the afternoon session, where we shall be having another session. We shall be starting with a presentation from Alex Adusei, the Executive Director, Women's Hope Foundation, titled Promoting Patient and Family Engagement in Global Patient Safety Action Plan in Africa. After that presentation, we shall have again another 15 minutes presentation titled Promoting Medication Safety in Patients Transitioned to New Drug Regimen by Cici Monera, who is a PhD holder. Then after that, we shall get into case studies from patient organizations. The first case study will be presented by Christine Mutena, the co-founder, Rare Disorders Kenya, titled Patient Engagement and Empowerment, Rare Disorders Kenya. Then a second case study will be about patient engagement and empowerment from Chain, facilitated by Ziwa Hillington, the Strategy in Programs Development Manager. Then we shall have another case study on cancer survivors engagement and empowerment, Tanzania Breast Cancer Foundation by Irene Impangile. Then a discussion for these subsequent presentations. Then we shall be coming to close where I shall be laying strategies for advancing quality and safety of care in Africa by the moderator. Then we shall have a wrap-up from Regina Kamoga, the World Patient Alliance board member. Members, I wish you lunch, and you can use 10 minutes before we return. Thank you. Bye for now. Hello, members. You are welcome to the afternoon session. I take this opportunity to thank you for having gone successfully through the morning session up to now. Thank you for sparing time and keeping around, but actively engaging as well. So we are still running our agenda, and you could see that we are now getting into the second session. And of course, this second session, we shall start with a presentation from Alex Adusei, the Executive Director, Women's Hope Foundation. Then we expect to have a presentation from Sisi Monera on promotion of medication safety in patients transition to new drug regimen. Then after that session, after that presentation, we shall marathon into case studies. We are having 4 case studies on our lineup. These are exciting case studies showcasing work around patient safety and patient-centered care. And we expect you to have a splendid afternoon. We shall be having a discussion after these case studies, then a call to action where we need your insights, your recommendations that all contribute to shaping patient safety. Then we shall sum it up with the wrap-up from Madame Regina, and we shall call it a day. So members, during this time, you can spare a few minutes for engagement before we are ushered into the subsequent presentation. You will recall that from the morning presentations, we've had good work done around patient safety in different states. We've had work from WHO, we've had work from NEPAD, where we had a good presentation from Dr. Janet Biarhanga of the African Union, where she gave us a lot of insights on work done around that. And of course, their project that is supposed to be done in 5 countries. I recall Southern Sudan as one of the countries and the Central African Republic. Of course, she had reasons as to why this work will be done in those selected 5 countries. There was a good presentation from Dr. Gertrude. We had another exciting presentation from Yolinde Baker of the Farmer Access. All these have been exciting presentations that have really shaped our discussions, thinking, and shape on universal health care coverage. The subsequent presentations are equally interesting. They are rich and insightful, just like the previous presentations. We had exciting work from Ghana by Dr. Ernest Konadu Asiedu, and we found that there is good leadership on healthcare from the government or the Ministry of Health in Ghana. I was equally impressed by the work of Dr. Janet Biarhanga of the African Union, but also work from Catherine Skippers of the Max Foundation. So from Dr. Jane, I realized that there is a lot of emphasis on community health workers. And this also applies in Uganda, but I've also seen in Ghana and in Rwanda as well, there is a lot of emphasis on community health workers. Yes, these are drivers of the healthcare system because they are on ground. They are the first contacts that patients engage with, and there are guidelines that are shaping their work. And I've seen that they are recommended to administer drugs, these antimalarials. They are doing work on immunization. They are doing work on around malaria using guidelines, the WHO guidelines, so they can dispense these first-line drugs. But of course, they can also recommend you for further treatment. But they can do work around malaria, work around health promotion, work around dispensing of probably, I talked of these dewormers, I've seen them, that they can access from the health facilities. Then they have this cotinam that they can dispense with these guidelines, but also with assistance from the health workers. So they are at the first, they are the first contact that the patients that the grassroots engage with. But there is a challenge that we are not seeing. For instance, in case they are not facilitated, or they are not having a payment, for instance, they are used as volunteers, they are always demotivated. And this quite bogs down the healthcare system. So they need to be remunerated. But of course, in some healthcare systems, guidelines are not yet in place. How much should they be remunerated? How often should they be remunerated? It is quite challenging. Some health systems say these are volunteers, they shouldn't be remunerated. This is a free service. Others say they should be really remunerated. So it becomes challenging. I don't know how. And I think Dr. Janet, you know it rightly from Uganda, that they are used as volunteers. There is a plan to ensure that they are remunerated in the new Community Health Extension Workers Program or scheme. So I also found that interesting. I would love to hear what other healthcare systems take on this. So at this juncture, please allow me to take you through the second session. Our speakers are lined up and they're very ready. Please stay tuned for them. You realize that the session chair is going to be Mike, Uganda. Hello, Mike.
Hello.
Hello, Mike.
Sorry, Mike, not Mike, but yes. Hello.
Yes, Mike, I'm waiting for you. So Mike is going to be the session chair. Hello.
Yes, Donnie.
Hello. Great, I'm happy to hear you. This is exciting. So George, you are the session chair from Mike Uganda.
Yes, from Story Mike Uganda.
From Story Mike Uganda.
Yeah.
Please, as the session chair, I hand over to you. Please take us through. You are welcome.
All right. Thank you, Donnie. Good afternoon, those who are in this time range. You're welcome to session 2 of our day. We are going to be having discussions and engagement on patient engagement in promoting access to quality and care, insights from patient organizations in Africa. We have prepared for you different people from different organizations, and they're going to be telling us a bit of their experience in this area. And from that, we are going to make some recommendations and get action points from that. The objective of this session is sharing experiences of patient organizations in engaging and involving communities and patients in improving quality and safety of care. We'll spend a whole day dealing with patient care and how it has kept changing over time. And the focus of this we have many organizations that have been dealing with patients. The focus of this particular afternoon session is going to be how these organizations can involve the communities in which they are. The communities, members of the community that are patients, and those who are not patients. And of course, that general description that a patient goes beyond a sick person, but anyone who needs services from healthcare workers. Yes, and how we can improve the quality of this care that we get. How much quality is this care? How safe is this care? Our first session is going to be tackling promoting patients and family engagement in global patient safety action plan in Africa. And we are going to be hearing from Alex Adusei. Ms. Alex Adusei is the Executive Director of the Women's Hope Foundation. He's a World Health Organization Patient Safety Advisory Group member and a patient safety champion in Ghana. He is also a human rights advocate and a community health promoter. He works as a researcher, a facilitator, trainer, and consultant on patient safety issues. Alex promotes health development and advocates for human rights, and these human rights include health rights. He has been working for over 15 years in community health promotion and development, and he has a special focus on health rights. You will find much of his work promotes gender equality and also the empowerment of women and girls. Right, currently, he is the Executive Director of Women's Hope Foundation, which is an NGO advancing women and girls' human rights and gender equality in Ghana. The title of his presentation is Promoting Patients and Family Engagement in Global Patient Safety Action Plan in Africa. You're welcome, Alex.
Hello?
Okay.
Yes, can you hear me?
Yes, we can hear you now, Alex.
Great. Thank you, Mike, for the introduction. Thank you very much.
George.
Okay, great, George. Mr. Chair, for the introduction. And the title of my presentation is Promoting Patient and Family Engagement in Global Patient Safety Action Plan in Africa. And I'm going to present it like you rightly mentioned my name, Alex Adusei from Ghana. Thank you. Next slide, please. All right, this is the outline of my presentation. I'm going to talk a brief about harm, patient harm, which is from the WHO source, the WHO World Health Organization data, and then Global Patient Safety Action Plan, like Dr. Gertrude has already, explained, detailed, and also interventions to promote the action plan in Africa, and a few recommendations from me. Thank you. Next slide. Okay. Research study or data from the World Health Organization source indicates that an average of 1 in 10 patients is subject to an adverse event, which is the harm, preventable harm, while receiving hospital care in high-income countries, developed countries. The estimate for the low and middle income, which is the developing countries, suggests that up to 1 in 4 patients is harmed, with 134 million adverse events occurring annually due to unsafe care in hospitals, contributing to around 2.6 million deaths. Overall, 60% of deaths in low and middle income countries are due to unsafe and poor quality care. Next slide, please. Next, please. Hello? Yes. Okay, right, thank you. So in the year 2021, the World Health Organization Global Patient Safety Action Plan 2021-2023 was adopted by the 74th World Health Assembly to address the global burden of unsafe care and reduce the harm. The Global Action Plan set for 7 strategic objectives to achieve the maximum possible reduction in avoidable harm resulting from unsafe care. Like I said, Dr. Gertrude has already mentioned some of the the objectives, the strategic objectives. So I'm going to talk about the strategic objective 4. And you could see it from the screen, the first page of the action plan. Next slide, please. So the Global Action Plan set for 7 strategic objectives to achieve the maximum possible. So the objective 4 outline patient and family engagement in all levels, such as informing, consulting, and co-developing. So within the strategies 4, there are some specific strategies within the strategy 4, where we have some 5 specific objectives under the strategic objectives 4. So the first one is to engage patients, families, and civil society organizations in co-development of policies, plans, strategies, programs, and guidelines to make health care safer. That is under the objective 4, the first specific strategy within the action plan. And then the 2, which is the 4.2, is learn from the experience of patients and family exposed to unsafe care to improve understanding of the nature of harm and foster the development of more effective solutions. That is the 4.2 of the specific objective 4.2. And then strategic objective 4.3, build the capacity of patient advocates and champions. This has to do with the training of people, community members, the healthcare providers to be able to champion, to crusade on the patient action plan implementation in all regions in Africa. And also the objective, under the objective strategy 4, we have strategy 4.4, which is to establish the principle and practice of openness and transparency through health care, including patient safety incident disclosure to patients and families. And next slide, please. Okay, thank you. All right. So the 4.4 I've mentioned, and then the 4.5 provide information and education to patients and families for their involvement in the self-care and empower them for shared decision makings. So in order to achieve this strategic objective 4, next slide, please. All right. So in order to achieve the strategic objective 4, patient organization is involved in advocacy and awareness raising in all levels of patient and family engagement. Like I mentioned in the first bullet, that we are going to inform, we are going to consult, and we are going to co-develop, informing, consulting, and co-developing to increase political commitment and then localization of the global action plan in order to achieve the maximum reduction in avoidable harm from unsafe care. So what patient organization like Women's Hope Foundation is doing in Ghana and here is what we can do to promote, like we are doing, is to first business good. Thank you very much. To advocate for patient safety as a national priority and promote global patient safety action plan. And then we also raise awareness about patient safety. That is the World Health Organization Patient Safety Day, medication without harm and infection prevention, and other aspects on the global action plan. And also we advocate and help develop and disseminate national patient charter, because Ghana here, like Dr. Ernest rightly said, we have the charter and we support the dissemination of the charter to our community people. And also we raise awareness about safety reporting system, the right to access medical record, the right to inform consent, and the right to an emergency response. Because we, the patient and the patient organization, there is a patient right that we must all exercise. So we did, we emphasize more on how we can cooperate or we can work with the duty bearers, the providers, to be able for them to give us, the consent from us and also inform us during the emergency issues. And also we advocate for patients as a human right, because a patient right is a human right. So we also advocate on that issue. And we advocate also for the transparency in healthcare system. We do also advocate for inclusion of patient families and communities in all safety planning and program at the national and local level. And also we generate data to be able to inform decisions, to influence change, because without data, you cannot work. So we use it to inform decision makings on patient safety issues. So we also recruit and build capacities and mobilize patients for advocacy. We do this by engaging more community-based organizations, community people, especially the women, to be engaged in their own healthcare. So to be reduce this, harms in our hospitals. We also develop and disseminate patient information materials, such as leaflets, banners, brochures to our community using our local languages for them to understand the whole, the issues we want to, communicate to. And we also create oversight mechanism for local health facilities and local patient assistance program for people who encounter problems in their healthcare problems. Because we have a situation that if you have any concern concerning the outcome of your health care, you can even come to our office for counseling, and also we pave way for mutual discussion to be able to address or redress the issue. And we also collaborate with the government to support the development of the national patient safety issues in Ghana. Next slide, please. Next slide, please. Hello. Hello.
Hellington. Okay.
Yes, yes. It's like it continues. So I'm reading, and then the slide will go like that. Okay, right. So I'm here. Okay. So we collaborate. We also identify and advocate for new patient issues in terms of developing patient safety charter. We also help in that way. All right. So my last slide, key recommendation. Yes, and this is the okay. Then the next slide before the key recommendation, please. Okay. So we also conduct advocacy and constructive meetings with key stakeholders, because doing this, it needs key stakeholders buy-in. Without their buy-ins, it's not possible to achieve maximum result. So we also engage and involve key stakeholders in advocacy meetings and other dialogues to be able to solicit for their support in promoting patient safety in Ghana and Africa as a whole. We also produce a special newsletter, and like I already mentioned it, we display it for community information. So the last slide, please. All right, thank you. The key recommendation, there is a need to continue engaging, engaging in the work that focus on promoting the global patient safety action through approaches that target the root cause, because we want to target this from the root cause, because if you want to reduce something, it's supposed to start from the root cause. So we emphasizing on, tackling the root cause, which is the delay, incorrect diagnosis, medication errors, surgical errors, unsafe transfusion, and other lack of infection control practices and poor engagement of patients. So these are the root causes. So we as organization, we tackle this, we address this in our end. And there is also a need for focus and consistent funding from the government and then international organizations to be able to promote, this global patient action plan implementation, because normally this implementation we have is there, the action plan is there, but when it comes to implementation, that is where the problems, the issues start. So to be able to implement this in Africa, the patient organization and then the patient themselves and their families need, consistent funding to be able to implement this in Africa. Thank you very much. Next slide. Thank you. Thank you very much.
Thank you, Mr. Adesei. That was quite, that was a rich discussion with a lot of, with a lot of strategies and interventions that you believe will solve this issue of unsafe patient care and how communities and patients can be involved. I think we're going to deal with a lot of that in the discussion later on. So let me move on to the next presenter. Our next presenter is Dr. Ceci Monera Penduka. She's an HIV pharmacy specialist and a senior lecturer at the University of Zimbabwe. Dr. Monera is an HIV pharmacy specialist and a senior lecturer at the University of Zimbabwe. Her research interests lie in the development of clinical evidence for the safe integration of herbal and conventional medicine in HIV care settings. Dr. Monera assisted in the establishment of the Parire Nyatwa Center for Excellence for HIV treatment and care. In her 3-year stint as the pharmacy manager of AHF Zimbabwe, she developed and oversaw the implementation of pharmaceutical care, pharmacovigilance, supply chain, training, and research initiatives to improve the quality of care of people living with HIV managed at the clinic. The title of her presentation is Promoting Medication Safety in Patients Transitioned to New Drug Regimen. You're welcome, Dr. Monera. Dr. Monera?
Thank you, George. I'd recorded my slides, so I think you need to play them. But if that's not possible, I can share my presentation and I can speak.
It's okay. Yes, Dr. Monera, we can play the slides.
Thank you. Please go ahead.
National HIV treatment program. As you may know, where medications are used to manage different healthcare conditions, there can be problems that interfere with the goals we're trying to achieve. This could relate to the dosing not being optimal, but also to safety issues such as adverse reactions, side effects, and interactions between drugs. In light of this, the World Health Organization has launched a global patient safety challenge to promote use of medication without harm to patients. And they've defined 3 priority areas which we need to look out for to reduce medication-related harm. These areas are settings where patients are transitioned from one care setting to another, such as being discharged from hospital, in settings where patients typically take several medications to manage different conditions, as well as in other high-risk situations where different factors could contribute to medication harm. When we come to HIV care in particular, drug-related problems such as side effects are associated with poor adherence and will lead to suboptimal blood levels resulting in drug resistance. And we really worry about drug resistance because we have a limited number of safe and effective antiretroviral drugs which we can choose from when making a regimen. In addition, drug-related problems also interfere with the UNAIDS targets for HIV management, where we are saying 95% of patients living with HIV should know their status, and 95% of those who know their status should be on ART, and 95% of those on ART should be virally suppressed. The dolutegravir transition exercise posts a high-risk situation for patient safety issues, because remember, we are changing practice and healthcare providers had limited experience with using dolutegravir. And most low and middle income countries are short-staffed. Their clinics are large and there's a lot of work pressure. By nature, also, ART makes use of multi-drug regimen in a setting where other chronic health conditions are common and managed by lifelong treatment. So polypharmacy is also prevalent. Ideally, at every patient visit, pharmacists should review all the medications the patient is taking so they can identify and resolve potential and actual drug-related problems. Many different terms are used to refer to this process. You may have heard the term medication therapy management or comprehensive medication management, or maybe medicine use review process. We developed and implemented this medicine review process to ensure safe transition to dolutegravir for patients at Paranyatwa Hospital. And I'll now share how we did this and the outcomes as well as the lessons learned. Our objective with this initiative really was to make sure that the right individuals were transitioned to dolutegravir for the right reasons, and that they took dolutegravir in the right doses through the right routes at the right time. We also wanted to make sure that any patient who refused the transition, their right was taken into consideration and the right document. So we collaborated with the University of Zimbabwe to get final year pharmacy students on vacation to work with the pharmacy manager over a 2-week period. They developed a patient wake-up tool to document clinical characteristics of patients being transitioned to dolutegravir. The students then conducted in-depth consultations with patients and caregivers and used the decision tree to help identify dolutegravir related problems and make recommendations for their resolution. A total of 129 patients, which constituted 10% of transitioned patients, were reviewed. And 76 drug-related problems were identified. In the process, we documented real-time any proposed interventions and changes onto the patient charts. 93% of the problems were resolved at the same visit by collaboration of the pharmacy manager with either the patient and the caregiver, the dispensing staff, or other clinicians at the clinic. During the period, we also initiated weekly reporting of adverse drug reactions to the National Pharmacovigilance Center, a total of 26 case safety reports. The drug-related problems which we were able to identify included adverse events, sexual and reproductive health counseling, TB preventative therapy, and preventive therapy for other opportunistic infections. as well as drug interactions. We noted that 51% of eligible patients had not been put on TB preventative therapy. 26% of women of childbearing age did not recall having the discussion about neural tube defects, which is pertinent for women in their first trimester of pregnancy before being transitioned. 11% were adverse drug events that have not been documented or discussed, and this included insomnia, which is difficulty sleeping, rash, and other transient or persistent side effects related to the gut. Actual and potential drug interactions were identified in 6% of the patients. This included interactions between dolutegravir and rifampicin, a TB medication, metformin, a medication for diabetes, and nutritional supplements that had not been discussed or adjusted for clinically. We also managed to contribute to quality improvement through this process. Quality improvement has 4 main aims. One is to improve the clinician experience, and we contributed to this by using pharmacy trainees to reduce clinicians' workload. Another one is to improve the patient experience, and we contributed to this by identifying and managing actual and potential drug-related problems. We're also able to increase uptake of TB preventative medications, and this will result in better outcomes for the patients, because we are saying will reduce their risk of acquiring different opportunistic infections. And all these 3 achievements also indirectly contribute to the cost of healthcare by reducing the cost of managing OIs and the cost of managing the complications related to adverse drug reactions and side effects. Our initiative tied on all the 4 domains of medication without harm framework, that is the patient and public, healthcare professionals, the systems and practices of medications, as well as medication supply and dispensing. So in terms of next steps, we are really keen to scale up this initiative. We're looking for funding to scale up the student electives to other teaching hospitals in the country, as well as to other regional university teaching hospitals we've collaborated with in the past. We're also looking for funding to scale up the medication use review process by periodically training pharmacists and other clinicians in private practice and other points of care. We also want to develop targeted patient education campaigns on common drug-related problems and roll them out widely. So we really couldn't have identified and resolved all these problems without the cooperation of patients and their caregivers. Patients and caregivers are an integral part of providing safe care and should speak out about their medication use experience. They should also engage with requests for information whenever they are approached by clinicians. This will ensure that their medications are safe for them and will also help to improve the quality of the care that they receive. Thank you very much for paying attention. These are some of the references that I used if you are interested in reading some more about our initiative. And I would also like to thank everyone who took part in making sure we're able to document and resolve all the problems. I'm happy to take any questions and suggestions in the question and answer section. Thank you.
Thank you so much, Dr. Monera. Thank you so much. I think everyone will agree that we have learned quite a lot. For me, what stood out in the drug-related problems was the poor adherence and the drug resistance among the patients, and how among the next steps that periodic training for healthcare professionals, because you kept saying many of the mothers, the women of childbearing age, could not even remember having these discussions. So maybe when there's periodic training, it will be more reinforced. And then, of course, patient education on drug-related problems, because at the end of the day, it is the patient, all these actions, it is the patient who is most affected. And it's amazing that in your solutions, you suggest solutions that based on the patient themselves and not just the government and other entities. Thank you so much, Dr. Monel. Our next presentation is coming from, we're now dealing with patient organization case studies on patient engagement to promote access to quality and safe care for the patients. Our next, the first case study we'll deal with on patient engagement and empowerment comes from Christine Mutena, who is the co-founder of Rare Disorders Kenya. Now, a little about Christine. Christine Mutena is an immensely passionate advocate for rare diseases and disability in general in Kenya and globally. These causes are more, I think, cases. These cases are deeply personal to her. Christine is a mother of 2 children, and both of these 2 children have non-related rare genetic conditions. So I think she's going to be telling us about it close to her heart. Christine is the co-founder of Rare Disorders Kenya, a patient-led organization that seeks to amplify the unmet needs of the rare diseases community, that creates awareness on rare diseases in Kenya. And they also run this Rare Disease Day campaign in which they reach out to policymakers. She is also on the Patient Group Engagement Committee of Beacon. That's the term of 2021 to 2023. Beacon is a UK-based charity that is building a united rare disease community with patient groups at its heart. Their events and trainings give patient groups opportunities to connect, collaborate with each other, and learn from each other, help each other, sharing information. She is also a founder of Step by Stones Association. This organization leverages social media and related digital platforms to offer support to its community. It runs a community of special needs parents, caregivers, and different psychosocial support specialists. Her life objective is to hone and use the skills and knowledge garnered through her personal. I told you she has children who have rare conditions, and then also professional experiences through the work that she has done. She uses all this to aid children living with disabilities so that they can live full, independent lives with dignity. The title of her presentation is Case Study on Patient Engagement and Empowerment. Welcome, Christine.
Thank you, George. That was a mouthful. I hope you can all hear me.
We can hear you.
Thank you, thank you. As rightly and very generously introduced by George, Christine Mutena is my name, and I'm going to take you through a case study on Rare Disorders Kenya and how we are aiming to empower and engage our members. For starters, I will introduce what a rare disease is, just for those who may not be aware. A rare disease is any disease that affects a small percentage of any given population, and they're usually serious, chronic, and progressive in nature. Most of them are lifelong, hence the need to continuously engage with healthcare providers in a multidisciplinary platform. These are some of the global statistics for rare diseases. There are more than 7,000 known rare diseases globally, and it is estimated 300 million people are affected by a rare disease. 72% of rare diseases are genetic, where you find 70% of those genetic affect children, and sadly 30% of these children do not live to see their 5th birthday. Only 5% of rare diseases have FDA-approved treatment, and hence you can see how grossly underrepresented they are. And rare diseases are recognized under the Universal Health coverage umbrella. The common challenges of rare diseases include misdiagnosis and delayed treatment, a lack of access to treatment and specialist care due to lack of knowledge, limited or non-existent treatment options. As mentioned earlier, only 5% of those conditions have FDA-approved treatment. There's a lack of information and support to disease progression, especially in this ultra-rare cases whereby you cannot find even somebody else on the same continent with that same condition. So you do not know what is your prognosis in life. Social cultural factors unique to Africa, we all know that, like for example, witchcraft, which leads to a lot of stigma and discrimination. So basically, in a nutshell, that is just a small introduction for rare diseases, about rare diseases. Rare Disorders Kenya. This is a patient-led organization. It consists of patients, parents, and caregivers who are looking to make a difference to those living with rare diseases in the country. The aim is to engage various stakeholders to address these unique needs, and these stakeholders vary from the ministry, the government, who incorporates the Ministry of Health, Ministry of Education, social, gender. We have pharmaceutical companies, we have healthcare providers. It's basically just to bring in all stakeholders that just touch the lives of anyone living with a rare disease together so that we can make life better for the next Kenyan. We have roughly around over 70 recorded conditions in our books, and some of the common quote unquote rare disease examples include multiple sclerosis, multiple sclerosis, muscular dystrophy, which comprises of spinal muscular atrophy, Duchenne muscular dystrophy. We also have narcolepsy, myasthenia gravis, and etc. The objectives of the organization is to educate and raise awareness. That's one, so at least more people are aware that rare diseases do exist. Now, the second objective is to improve lives of those living with rare diseases in the country. We also collaborate with other stakeholders so that we can make a difference and improve outcomes of Kenyans living with rare diseases. And then the last is to promote research around rare disorders in the country. We're currently doing a baseline study, conducting a baseline study on rare diseases on 2 primary healthcare hospitals in Nairobi. Road to patient engagement and empowerment. We have roughly put our outlook into how we empower our members through these 4 steps: member acceptance, advocacy, patient skills, patient-centric care. I will go ahead and describe them individually. Member acceptance. This is through helping our members accept their conditions, acting as an information hub for their conditions, linking them up with disease-appropriate support groups so they can get further day-to-day hacks and how to handle their conditions. We also look to engage mental health specialists to partner with us to give us psychosocial support as much as we are offering peer-to-peer support. Advocacy. Rare Disorders Kenya, RDK, is working with the government to create policies around rare diseases at a national level. We are doing patient rights and affirmation, so at least we can ensure our members do know what their rights are as patients, as earlier said by a speaker, I can't remember who, and also knowledgeable so they can make informed decisions when they're dealing with healthcare providers. We encourage our members to be their own champions, so as not to wait for the organization to be their champion, but to build that within themselves so they can rise up and be their own champions. And this can be done through sharing of their stories. It can be done through media, through either social or print or mainstream. We've also do it through groups that we meet, like as you can see in the photo On the page, that was a meetup for different members of our community, just to sit and understand what the other person is going through. Patient skills. Patients develop an ability to make independent and informed decisions, and then become partners in their healthcare environment. This is through health literacy, whereby if I know what is going on with my condition, and then you see with rare diseases, you find that the patient tends to know a bit more than the healthcare provider, given the scarcity of the condition and the intense research the person affected has done. We advise and we try and train our members to understand what they have, so that when they're making, the doctor or the healthcare provider tells them this and that, it's a discussion on the table, not a top-down approach, so that they can adopt a proactive mindset to their condition as well. And then the last item is patient-centric care, facilitating environment with dignity and respect and involvement. That is the definition of patient-centric or centered care. And this allows, this can only be feasible if the environment is conducive for that. And allowing linkages of different institutions and patients and specialists together creates that environment, because you bring them together in the same space and they share ideas and knowledge and an outlook on how to go managing rare diseases. Interaction with healthcare providers is as a key stakeholder is imperative for us as an organization, because we tend to give them the different aspects of rare diseases. We do this through either CMEs, continuous medical education webinars, or it can even be as something as simple as a rare disease day event, where we invite them to come and attend and get to understand where we're doing. This is also feasible through interactions with international organizations, whereby international organizations come through us to introduce them to doctors who are rare disease oriented, in terms of willing to learn. And also we share our members with them when it comes to compassionate programs. Then that leads to a mutual relationship between RTK and healthcare providers. In conclusion, patient engagement and empowerment is a delicate process that involves trust between all stakeholders. It is not a rushed process, and it should be taken with like eggshells, because it is trust that is involved here. It cannot be imposed, but it can be facilitated, meaning that you cannot force a patient to be empowered, but you can help them understand the path ahead. Patient advocacy groups should be treated as partners and key stakeholders when it comes to patient quality and safe care. And I think this is something that cannot be enhanced, cannot be enhanced more than this, because you find that without patient advocacy groups or patients, then you cannot have a patient-centered care for your patient. I think that is all through our contacts. So yes, I think that is the end of my presentation. Thank you.
Thank you so much, Christine. Your presentation has related to me a lot, because you hear people call me Mike. That story Mike that I run, it's a live storytelling monthly event, and it is themed. So I saw that in a lot of your strategies, you have a focus on mental health and on how people should share. And I greatly relate to the importance of when people share similar stories, and how that empathy and connection does a lot of difference. I think rare disease disorders is really a real case study of patient engagement, because it's very patient-centered. You're telling your people to be their own champions, and that because they're the ones going to be affected most by whatever they are suffering from, they should get up themselves and push for further research on these things. Because I saw one of the challenges you found is that there's always late, there is that problem, yes, or misdiagnosis, because it's already a rare disease. There is that problem of misdiagnosis. And now with research on it, instead of the doctor sending you, we have a problem of herbal medicine here. Okay, not a problem, but yes. But now if there is information on this, and people have come together to advocate for this, I really love what Rare Disorders is doing. And I wish you the best of luck.
Thank you so much,
Now,
George.
okay. So our next presenter is Mr. Ziwa Hillington. He does strategy and programs development at Chain Uganda. Maybe a little about Mr. Ziwa. Chain Uganda is the Community Health and Information Network, Uganda. Ziwa Hillington is a business management expert and a social entrepreneur based in Uganda. For 10 years, he has worked with expert teams and local community members to innovate and advance strategies for distribution of life goods and services at the last mile in Africa. Explain what that means. In 2009, he joined Chain, that's the Community Health and Information Network, as a community support volunteer. And now he does pro bono consulting on strategy, development. His work focuses on blending philanthropy and social entrepreneurship. This is to improve access to quality healthcare. He is a social entrepreneur. He manages an entity called Green Bioenergy. It is a social business in Uganda, and he has worked there for 10 years. His work advances social innovation and distribution of life goods and services, as well as the social business framework. He aims to fight poverty, climate change, and health inequities. His presentation is titled A Case Study on Patient Engagement and Empowerment from Chain, Community Health and Information Network. Let us welcome Mr. Ziwa.
Thank you very much, George, for the introductions. George has clearly explained what I do. It's a pleasure that we have everyone here today. I will tell you about Community Health and Information Network, what we do, and then specifically elaborate an interesting initiative that we have at Community Health and Information Network that is focused on the young people that are in school. We call it the Chain Start Early in Life Initiative. But before that, allow me give you some background about Community Health and Information Network. So Community Health and Information Network, which is Chain, was started in 1998 by a group of African professionals who were residents in the United Kingdom. At the wake of the 1998 Geneva World AIDS Conference. Post that conference, Chain was founded in Uganda in 2004, and the executive director at Chain is called Regina Namata Kamuga. Through time, Chain has grown into a network of community-based caregivers, which include patients' organizations, health experts, community health workers, all these coming up with ideas that transform into interventions, and these interventions will address barriers to quality health care amongst the most isolated and vulnerable communities. Now, the biggest song with Chain is that we are the community champions in the communities where we operate. And when we are the community champions, and this is a group of individuals, organizations, we are Secretariat of the Uganda Alliance of the Patients Organizations, and many other associations, even patient groups in the community. Now, with the interventions that we do, we have a slogan. We say that we are creating the resilient African expert patient in the underserved communities. We want policy to speak to our patients while it understands them. We want government to make decisions on our patients while they understand them. And so we are there to create and enable quality health services, also bridge the information of the different stakeholders, including the policy makers, including the supply chain networks and investors sectors, including the healthcare providers. And healthcare providers, you mentioned the community health workers who are popularized as the village health teams, and then the expert medical personnel. I'll give you examples in the next slide. When we say healthcare providers, what do we do with them? When we say the policy makers, what do we do with them? When we say the supply chain and investor networks, what do we do with them? And then the patient groups, from village patient groups to alliances like the Uganda Alliance of Uganda Alliance of Patients Organization in Uganda. And while we work, of course, we are addressing the issues related to access to quality. But once again, to emphasize, it's not access, just access to quality. We are saying access to quality health care for isolated community members. Our approach to create this resilient African patient, of course, starting with the Ugandan patient, has 3 building blocks. We have an infrastructure. The chain keeps on evolving through time. Then we have the services that we provide, and of course, the beneficiary ecosystem. We believe that all interventions should be encompassing the different value chain key resources. And in our infrastructure, most important, we work with the patient groups. I did mention that chain is the secretariat of the Uganda Alliance of Patients Organization, which has very many organizations in different regions in Uganda. Here there are 2 areas: capacity building for the patients' organizations, data collection about the patient so that the interventions can be data-based or evidence-based. From the patients groups, we have the community health workers and then the medical experts. The community health worker, who is a village health team member, is so critical to us. They're the people that the community speaks to. It's common that people can buy or can listen to people that they relate to. So we have created a network of at least 50 village health team members, not just creating, but also empowering them through health trainings, empowering them, providing financial incentives to ensure that they reach out to their community. In fact, they have a great role in bridging the information gap. So this is what happens. Patients sometimes are hesitant to go to public or private health centers. Sometimes they would want to do self-medication. Sometimes they're biased about the public or private facilities. Sometimes the bias is true, sometimes the bias is wrong. And so we are saying, how can we break these complexities? And one approach is working with village health teams. That includes men and women, moving around with pens to register what are the issues in the communities. Who are the pregnant women? What are they facing? Are there nutritional issues? And once we are collecting this data, we start developing interventions that are customized and adaptable to the issues that are happening within the isolated communities. And then another important aspect is data, which is already, data cuts across within our infrastructure resources. So the community health workers will collect the data, the patients groups also collect the data. And the idea here is that even when we go to advocate for policies, we need actual data. An example, our executive director, Regina Namata Kamoga, is working with the National Drug Authority to promote, to empower communities that they can report on the adverse effects of the medicines they are taking. And so here we are working with a policymaker who does a bit of supply chain development, and we are saying, how can we improve the results of medicines for our community members? And so we are saying, let's go talk to them. There's an SMS. So Regina has been advocating for SMS reporting amongst her community members in the different districts where we operate. Just to mention again, which I'd forgotten, is about the medical experts. Now, there's an assumption that medical experts, they know and they're well versed because they are learned, but there's a very big issue that is happening. What happened to continuous learning? What continuous learning facilities are provided by both private and public health institutions, or by government, or by civil society? An example I'll give, in one of the public health facility which we support in Chivoga district, there was an issue that the healthcare provider, the medical expert, one of his issues was that he had taken a long time without updating his knowledge. And so he keeps on doing the same thing that he learned possibly 5 years ago. And because there's no sensitization, there's no knowledge development, he will do the same thing. So this doctor is an expert in his own world, but disease agendas change. Social demographics of the communities we serve change over and over time, even on a monthly basis. And this has been visible, at least in Chinese experience, because we are usually with these communities. And so we ask ourselves, what happens to this medical personnel who's not receiving continuous education? And therefore we say it's very important to have such a key resource in our infrastructure. The others is the Community Health Institute. This is progressive. Most of these infrastructure resources integrate within each other. Now, what we mean by the Community Health Institute is continuous education for the community health workers, like the village health teams, for the medical experts, and of course, the supply chain networks. There's a case that the supply chain networks would need data that informs their distribution of drugs, whether in private clinic, whether in public sector clinics. And so we are there to tell them this is what is working and this is not working. We think you can work with a specific community that has these issues, and also telling them that the proximity of the near proximity of communities does not necessarily mean that these communities might have the same issues or react the same way when you bring an intervention. So we are developing the Community Health Institute. About 5 years we've been planning this, and we want to continuously streamline knowledge development for community health workers, village health teams, medical experts, any other stakeholders, high-level stakeholders who would want to understand communities. Then the other part is a community health center. A community health center will have a resource center for the youth, where the youth come in and learn about permaculture. Permaculture is an improved way of farming. The community health centers will be a place where we will partner with patient organizations to come sensitize people on breast cancer, come sensitize people on medication safety, not just the patient groups, but also the medical experts. In fact, we have at least 50 medical experts that we are working with. These are medical doctors with a lot of experience. They're integrated within our Community Health Institute or knowledge building sector. But once again, at the Community Health Center, that everybody in the community will access this. So you have a Community Health Center, for example, right now in Wakiso district, we have one. And then you have micro support systems, including the patient groups, including the community health workers. And what do we provide at the end of the day? Data which is critical, so that we provide, so that we develop evidence-based interventions, basic healthcare services. This is both indirect and direct, through the patient, the patient organizations, through the government, through the private sector. We also distribute health products and medicines. One of our recent projects under this has been an almost 3-year project, possibly, that has been distributing solar water purifiers to address the issues of hand washing, issues of diarrhea in our community. Then the most pivotal and critical community health and information network is health literacy and patient safety. This has been embedded into Chinese DNA from the start to date. We are making about 20 years And this is thanks to the efforts of everyone who has contributed to change. But going back, health literacy and patient safety is embedded into all our programs, into all our strategies. And it's one core model that we are developing and promoting. And lastly, health advocacy. This is to talk to our supply chain networks and investor networks, also to talk to the policy makers. And so the beneficiary ecosystem, first and foremost, is the patient, family, and community. We are targeting the patient, the family, and the community members, but coupling different key resources and different approaches. Now that's about chain overall. I will now focus on the Start Early initiative. The Start Early initiative is a partnership with schools, different schools in Uganda, and we are creating the young community mobilizers, the young people who talk about patient safety, health literacy, and these are in both public and private schools. So we realize that there's a gap. There are doctors who are being trained about something. There's a bit of sensitization for other different types of stakeholders. But what happens to the children? Sometimes we are hesitant to talk about patient safety and health literacy with the children because they're like they're complex terms. So what Community Health and Information Network has done is to break the complex terms within health literacy and patient safety. And we have developed a program that has run at least for 5 years in public and private schools. I'll give you examples of outputs from this program. So for example, in one case study, we engaged 50 schools from 3 districts, including Chiboga, Wakiso, and Mpigi. These are locations, districts within Uganda. But this is just one case study. There are more activities. And some of the approaches are very basic. It's something like debating. So what happens, Community Health and Information Network will build the capacity of the teachers to learn about health literacy and patient safety. And then after that, when the capacity of the teachers has been built, we now start streamlining the training to the students and the pupils in these schools. That at the end of the day, some of the outputs are about patient safety. And of course, we break the complexity of patient safety. For example, for the World Patient Safety Day in Uganda, Chain is sensitizing a number of schools to debate on medication safety, which is the theme for the World Patient Safety Day. And our members are with the teachers, first building the capacity of the teachers to understand this, and then building the capacity of the children. Another output is music, dance and drama on health literacy and patient safety issues. So China's approaches or interventions that are adaptable to the community. And one of them is community music, dance, and drama. And so these are examples. There's so many more. And some of the outcomes, for example, we have installed 50 health literacy clubs in isolated schools in our communities. We will come if you visit Uganda, we will be happy to take you around these schools. But what happens when you set up this health literacy? That the children have continuous learning on different issues affecting them, and not just them, but also their parents and communities. And going back to where we said we are creating young community mobilizers, so the child has the capacity to direct their parent on where to get the right drugs, or even train their parent on how to take the drugs. So such an approach, while we're doing this approach, is that we know that the children engage with their parents, with their families, with their communities on a more open basis. So how do we ensure that patient safety happens even at family level? Another important outcome, at least 1,000 households are having hand washing tools at home. These are the examples, Tippetaps. Tippetap is a tool, is an apparatus that is used to wash hands. 1,000 households within the different districts we are operating have built these hand washing tools. Diarrhea is decreasing. Another important thing is about building toilets. Also, kids have become awareness advocates. You know, mom, we should have a toilet at home. Dad, we should have a toilet at home. For example, in Chiboga, through such approaches, more toilets have been built. Now, I'll play for you a small video, if you don't mind, just to show an example, an activity with the school. Thank you very much. Let me I'll put up a video very quickly. Just give me a minute.
Attention. I had done one.
Hope the internet works, but
Attention. I had done 1, 2, 3, go. Medication. Please. To demo. Kali. Medication. Safety. Is important. Nera. Medication. Safety. Is important. Thank you.
So one last video, that's an example of one of our staff members having a few kids talk about medication safety. Just a minute. I will put up one last video to end this. And the next video is about a group of kids that have been trained that medicines should not be shared. Unfortunately, we didn't have the time to put subtitles, but we are hoping that it works. Just give me a minute, please. So thank you very much for listening to me. Last video was about a training that medicine should not be shared. And this is an example. We are streamlining it in all different schools. It's one of the interventions that we do among all the different interventions. But most important for us is creating interventions that are community focused while working with the communities themselves. Thank you very much, session chair, and everyone for listening to me and being patient with me.
Thank you, Mr. Ziwa. Thank you so much for your presentation. I think the main thing I picked from that was the fact that people in communities, since you're working with local communities, people in communities deal a lot with people they are used to, people who they know, people who they trust already, and how all these, that's why a lot of your activities are based locally, geographically, in the communities, the community health centers that are going to be more than just a treatment place. But the interesting thing I heard about that continuous learning facilities. In the legal sector, we have continuous legal education because of the need to continuously update your brain on these things. So I think that was very interesting that you want health workers to engage in knowledge development. You keep teaching them, you keep refreshing their minds and telling them about new treatments because these things change every day. And also, of course, the young community organizers, so that children grow up well versed with patient safety. A few years ago in Uganda, we had the PSA program where children in primary schools were taught about HIV/AIDS, and I think most of the knowledge I have on HIV/AIDS comes from that exposure from PSA. So thank you so much, Mr. Ziwa Ellington from Chen, Uganda. Our next presenter is Irene Impangile from the Tanzania Breast Cancer Foundation. Ms. Impangile is a program volunteer at the Tanzania Breast Cancer Foundation, and her case study is on cancer survivors engagement and empowerment. Welcome, Irene.
Thank you very much, George. Good afternoon, everybody. So my name is Irene Mpangile. I'm actually a program manager. I do a lot of NGO work. I'm employed at Tanganyika Christian Refugee Services, but I have been supporting and doing a lot of work with Tanzania Breast Cancer Foundation since 2019. I would have loved to get the founder here today, but unfortunately today we have community engagement in Morogoro, which is the eastern part of Tanzania, and so everybody else is there. So yeah, it was my job to do the presentation, so I hope to do a very good job. So basically today I'm just going to go through what TBCF does, and TBCF is the acronym we go by at the moment because Tanzania Breast Cancer Foundation was founded by breast cancer survivors, but over the years we evolved and started incorporating cervical cancer. So now we're trying to just go by the acronym TBCF so that we can be inclusive of other cancers as well. So yeah, if you can go to the next slide. Yes, as I said, it was formed in 2008 by a group of 6 warriors that had beaten breast cancer by then. Unfortunately, 4 of them are deceased, but we still have 2 founding members. And the aim at the time was to raise awareness about breast cancer and get women to do regular checks. And basically, they started working with Ocean Road, which is a Ocean Road Hospital, which is a cancer institute in Tanzania. It's a government institution. Hospital. And we have been working with Ocean Road ever since 2008 to date. And these survivors really wanted to raise awareness because the stigma around cancer, specifically gynecological cancers, which is breast cancer, cervical cancer, is really bad in Tanzania. So their aim was really just trying to get the word out there that if they could beat it, and every other woman can. So our main work is really to raise awareness and to support individuals affected by breast and cervical cancer. And we like to reach out to the rural settings of Tanzania. So we believe that more urban areas have access to hospitals that can cure cancer, or not cure, but treat cancer, and we have information. But when you go to the outskirts of Tanzania, to rural Tanzania, the information is very limited, and even the services are limited. So we try to raise our voices to people who cannot get who don't have the access to information. And really our objectives are to shift the current stage of diagnosis from stage 3 and 4, because that's the time that people usually go to the hospitals and it's kind of late to treat the cancer, to its earlier stages, which is 0 to 2, where it's easier to treat. And we also provide emotional and financial support to affected individuals. Again, our focus is on patients or people who don't have as much money, so we would support them, the transport. So the good thing is that the government of Tanzania has subsidized a lot of treatments for cancer, but sometimes it's just the little things like transport money to get from where they are to the health facility, and we will provide that. And sometimes even they will come with somebody who will support them through treatment, and we will support that, not all the time, but sometimes when we have the funding, we would do that. And another objective of ours is to really engage with authorities and similar organizations and hospitals to really enhance our outreach, to make sure that the word goes out there, because we believe early detection saves lives. Next slide, please. So the cancer burden in Tanzania is really, we kind of, we group it into like three. So structural, which is the lack of resources. And this is like lack of facilities that adequately detect the cancer. And that sometimes leads to the late diagnosis of cancer. Because like if there are no hospitals in where people are, then people will just resort to traditional medicines and go about their day. So yeah, also systemic, so lack of education, that's one of our biggest challenges because people just don't know, and the fear of unknown is also bigger than you'd imagine. Socioeconomic factors like financial limitations and in rural, especially rural communities, is one of the reasons that contribute to the cancer burden. And the social cultural, so the fear of screening. People are afraid of, if I get it, if I'm seen with it, what will happen to me? The stigma around the diagnosis is more than you could imagine, and the fear of vaccination. So like there's the HPV campaign rolled out by the government, and it's very sad because like a lot of parents were telling their kids, no, if you get this one, you'll never give birth, and the negativity around it was so major that it really did hinder the rollout. So not a lot of kids got it. So social culture, I think, is one of the biggest hindrances, and that's what we're trying to educate the public that, you know, there are people who've had this HPV vaccine and they're living their lives. So yeah, next, please. So why do we do community engagement? We believe that, first of all our work, most of our work is done by the survivors themselves. Because we work with them as patients and we see them through until they've been treated. And some of them become members of our organization and they'll help us spread the word. And for us, it's been very impactful because it's better to hear from somebody who's gone through it than just hearing it from, let's say, a health professional, because like they're able to speak to somebody in their own communities that went through cancer diagnosis and treatment, and then they came back alive and well, and they're still able to continue their daily lives. And this has worked for us because then we've had members all across Tanzania who are still spreading, who's still advocating for early diagnosis, and they're still doing group support work as well. So this is really, it's really trying to reduce the burden in a certain extent, where education, like we don't have to be out there in stages all the time. It could just be doing 5 people at a time, and for us, it's been very, it's been working for us. Yeah, next please. So the kind of work that we've done over the last 3 years, even with COVID. So as you all know, Magufuli only put us on lockdown for 2 months, and then it was business as usual. But as Tanzania Breast Cancer Foundation, we took 6 months off. But then our services were still required. We were still being called to still provide psychosocial support. So we were out for about 6-7 months, but we were still able to engage people. So prior to COVID, we were doing home and hospital visits. And we worked with Mwimbili Hospital and also Ocean Road, where we would visit patients who were given their diagnosis and then they didn't want to maybe do the treatment, or they were afraid, let's say if they had a mastectomy, their husbands will leave them and their communities won't understand how are you a woman with no breasts, or, you know, so we were still having to do a lot of home visits and hospital visits prior and during 2020 towards the end, and 2021 and even up to now. And through these home and hospital visits, we're able to reach 4,000 people. Again, this is not only done in Dar es Salaam, this is done across Tanzania, where we have ambassadors and survivors. We also provide counseling services for for people who have had the mastectomy done and their husbands left them, or the society or the communities have shunned them, where we try to counsel them, we try and see other ways that they could earn an income, but also like patients who have been previously diagnosed, we would sit with them and just discuss that there is life after cancer. We also do awareness seminars, again, for the public, where sometimes we just stand in marketplaces and we will just spread the word. We do awareness events. We did charity work. We couldn't do one in 2020, but we did a virtual work in 2020, which was really good. So most of our charity works happen in Dar es Salaam, but the virtual one just, you know, we try to advocate for like other regions to do it. So that one was successful and we're very grateful for it. But it also helped open doors into other regions as well. So that was a really good, I know it was COVID time, but it was also a positive impact for us. We also provide mastectomy bras. This is like after a woman has had a mastectomy, we try to lift their self-esteem by providing them with bras and a fake boob, so they still feel confident with themselves as a woman, and life can go on without them feeling like something is missing. During COVID time, we did lost a lot of our funding, because our funding, instead of funding for our type of work, went towards clinical support. So, but we still managed to raise funds using sponsorships and memberships as well, because we are now a membership-based foundation. So that has kind of kept us afloat, but we still, whatever little we make sure that it goes towards supporting the survivor and the patient. Next, please. So like, since the day before yesterday, we've had like an awareness seminar happening in Morogoro, as I said. And this seminar, awareness screening, is partnered with the Tanzania Cancer Comprehensive Care, which is the DCCP, the district medical officers of Morogoro, Aga Khan Hospital, and other stakeholders. And basically what we're doing is we're trying to get the woman in the village to come in and get a screening and be made aware about cancer. But this time we're not only doing breast and cervical cancer, we're also doing prostate cancer, because every time that we go out to even corporates to speak about breast and cervical, everybody's asking us, what about prostate? What about prostate? So it is my hope maybe next year we will change our constitution and include prostate cancer, because at the moment there's not many people who are actually advocating for prostate cancer, and it is a big problem. And we actually have survivors of prostate cancer that we're working with even in this campaign that's happening right now. So we are hoping that we will widen our horizon and even look at prostate cancer. But at the moment, that's what we're doing. And then there are a lot of men who are coming up as well. So it's we're surprised, because men are very difficult to come and speak about prostate cancer. So it's a positive thing. And so our prostate cancer survivors, what they're doing is they're not speaking in public, but they're going to groups of men and they're talking about it. And that's been very powerful. In October, which is Breast Cancer Month, this year, instead of doing a charity walk, we've decided to do something a little bit different, which is we're doing maybe killing 3 birds with 1 stone. We're going to commemorate Breast Cancer Month in Kilwa, which is southern of Tanzania, by planting 1,000 trees, but it looks like maybe it will be more trees, because now we're trying to get sponsors for the trees, and it's been good. So with that, we're trying to promote obviously environmental management, but also like commemorating the lives lost during breast cancer, and symbolizing hope for like a better future. So if you get treated early, life will go on. So we're trying to show that breast cancer is not the end of the world, by planting a tree. And that's something that we're now working on, and it should happen on the October 15th, but we're not too sure if it's going to happen then or later, but it will happen in October. Next, please. So in a nutshell, that is TBCF. But where do we get our funding? So we used to get funding from donors, and since COVID, like I said, we've had to raise funds other ways. We've had to do events, we've had to do memberships, and luckily we've partnered with different corporates who sponsor us for events. So this event happening in Morogoro has been sponsored by Tanzania Revenue Authority and other organizations, other corporates. In Kilo, again, we also have another corporates who are sponsoring that. So we've been lucky enough to get that kind of funding. We don't really do like scientific patient care, but we do it in psychosocial support. So sometimes the nurses call us themselves or the doctors and they say, we have patients here that need your support. So we'll send our survivors and then they'll go and speak to them, and they'll have like intimate conversations and get to know them. And yeah, it usually works really well, because then the patient is not as afraid of the cancer diagnosis as they were prior. We thrive with our long-standing relationships with the Ministry of Health, with hospitals such as Aga Khan and Ocean Road and Wimbili National Hospitals. So our partnerships really do elevate the work that we do. TBCF would not be where it is without our survivors. So our survivors they push most of the things that we do. They are the light of the organizations, because people tend to believe their story, listen to them because they've gone through their stories. They're just normal people like them. So we don't only focus on life prior, we also look at during the cancer diagnosis and post-cancer. And their lives do change, but to what extent and what else can they do? So I focus a lot of energy on survivorship. We're living a normal life after beating cancer. And we really do advocate that there is life after cancer. I think for me, that was it, because it was a very short presentation. So yeah, that is TBCF in a nutshell, and that is how we evolve the community. I think I saw a question about HPV vaccine. I couldn't even read it.
Yes, the question was in relation to what you have done to reduce that fear for the HPV vaccine among communities.
So for us, we have gone to schools. The mistake was done that the HPV vaccines went out before actually educating the public about what it was meant to do. So the government has slowed down its rollout now, and now we're doing a lot more, trying to now inform the public that this is what the vaccine does. Now, since COVID, that has not been happening, because now it's a COVID vaccine and you cannot be advocating for all these different vaccines at the same time. But our approach was really going to schools, especially secondary schools, and teaching them, but also having community engagement with religious leaders and local community leaders, because then they're the ones who are able to push their agenda better within their communities.
Yes, thank you. And yes, Nduka, I do agree with you as well. Patients as popular opinion leaders, it's one thing that has been appearing in every presentation. Thank you so much, Irene Panjire. I think it's amazing, among other things, that your organization focuses a lot on stigma, in a way, on dealing with this negativity. And it's something we also have here, a lot of negativity and misinformation over these vaccines. So I think awareness is so crucial. Today, I heard you mention that groups of men that deal also with prostate cancer. Today, I read a lot, I find a lot of information about prostate cancer. It was such a silent killer for so long, and people didn't even know when they should go for testing for those things. I love that your organization wants to get women to do regular checks. I have read many breast cancer stories, and most of them, this cancer is discovered in the late stages, late 3 and 4, stage 3 and 4, as opposed to when you can still do much. So I like that your organization does a lot of that. And then most interestingly, that you don't offer just emotional support. I think as an organization I've had that offers also financial support to these women, because emotion is important, but we also know the beauty of the power of financial support to a cancer patient. Thank you so much, Irene. That was amazing. So we are moving on to our last case study, to our fourth and last case study today. Fatima Sidat, who is a development manager at the South African Depression and Anxiety Group. Her case study is on initiatives that are based in settlements. Maybe a little about Fatima. Fatima has a postgraduate degree in psychology and has worked in the mental health sector for over 10 years. For many people in Africa, we are finding mental health to be, the focus on mental health is a bit recent, but Fatima has been in it for over 10 years. And her passion is working within communities, raising mental health awareness and creating programs to help people understand mental health better. Currently, she's a development manager at the South African Depression and Anxiety Group, and she contributes to innovative ways to create more resources for people that are seeking mental health. She helps raise awareness on mental health and also helps with fundraising and managing the Depression and Anxiety Group's Rural Container Counseling Project. Welcome, Fatima.
Hi.
Hi, Fatima, you're
Yes.
back.
Yes,
Great.
yes. Yes.
You can continue.
Okay, Fatima, we're so happy to have you back. We
I
already
have no idea what happened.
we already introduced you, so I think you should just take over the presentation.
Hi, everyone. Good afternoon. It's such a privilege to be part of this program, and I'm probably following up from very, very good initiatives that's been happening, and I feel very part of this. So, thank you for the introduction. I'm Fatima Sidat from the South African Depression and Anxiety Group, and I predominantly oversee our rural outreach programs, which works within townships in areas where there's little or no access to mental health. And I think it's so important that we provide the services, because many people go undiagnosed, untreated, and they, in the long run, it has a long-term effect on each and every person. So what we've done at the South African Depression and Anxiety Group is create, we started a pilot project, and that pilot project is running for, I think, 10 years. So we have our second project now running as well. I'd love to speak about it. So if we can go back to the next slide. I'd like to introduce SEDEC to you, just so you know a little bit about us. We were established 28 years ago in South Africa by our founder, who suffered with anxiety, severe anxiety, and she struggled to get help. And what resulted from her struggles was opening up a mental health NGO. We are one of the largest mental health NGOs in Africa. We do support, we do train, we do workshops. Our services reach out to everyone within Africa. At times we help people in Nigeria, in Kenya, in Uganda. We try our best to support everyone, but also to empower different people in different countries to start their own initiative in their countries. We do a lot of patient advocacy and awareness. So we work really hard to improve services for mental health care patients within South Africa, especially those that cannot afford it. We also create awareness because we believe that the more education we provide to the public, the better knowledge they have of mental health, and the better they could get or receive the help that they need. We run over 30 toll-free helplines. They're all mental health based. So we do university lines. We have the only suicide crisis line in South Africa. We have a mental health helpline as well. And we have all specific helplines relating to mental health problems. We have SMS helplines, WhatsApp helplines, and that's because with currently a lot of people with technology, they feel more comfortable reaching out to us on different levels. So we do get people reaching out for help via SMS, WhatsApp, emails, social media. People contact us desperately for help on different platforms, and we try our best to be there for lots of people, especially post-COVID, where we used to receive about 800 to 850 calls per day. Post-COVID, we're reaching over 3,500 people reaching out for help. And that is a huge amount of people seeking help for mental health issues. We do, the counseling containers are something that we are going to discuss further, but it is one of our big projects and initiatives that we've tried and tested, and we see how great it's doing within communities. We do employee wellness programs, school talks, which is one of our big elements, even in our rural areas. We do rural outreach programs where we go into remote areas where there's no help or services. We train people to open up support groups. We train people how to do basic counseling and to provide a service that isn't available within the area. We have a very another innovative program, which is the Speaking Books. Speaking Books is basically it's a literacy book where we try and promote health, different health programs to different communities. And it's targeted for people that are semi-literate or illiterate, that aren't able to understand reading that well. And these books help them understand different health issues better because the book reads to them, which then helps educate the people that we distribute the books to, but also people around them. We did research around it, and each book reached over 120 people, which is our main aim of this whole program today, is education for patients, but also to help them manage whatever condition they are going through. Next slide, please. So in South Africa, mental health, and I think globally, mental health is a huge issue currently, especially after COVID-19 has hit most of us. It's left a lot of trauma, a lot of grief, depression, people that are struggling with financial issues, and other different issues that they may be going through. 1 in 3 South Africans will or do suffer from mental illness in their lifespan. And we're starting to see more of it because the more we see people reach out to us, we know that more people are being impacted by mental health. From that, unfortunately, only 25% of people have access or will have access to treatment, which is really absolutely unfortunate because the many people that are going out being untreated have long-term effects, which means they suffer not only mentally, but also physically, and also in the environments. It has a huge impact on their livelihoods, their lifestyles, family members. It's almost a spiral effect that happens to each and every individual if any mental illness goes untreated. So 75% of people living with mental health issues are not getting access to treatment. And that's where it leads us to our initiative and our pilot project that we started 10 years ago. Next slide, please. So our initiative was to create some sort of service to areas where there isn't services available. So what we've done is we wanted to bridge the gap of patients that weren't able to receive the help that they needed. And the only way we could think of it is to create some sort of center or office within those areas so that we could place trained counselors to assist them further. So what we've done is we've taken shipping containers, converted them into mini offices, which could be part of any. So in South Africa, they have township area. In the township areas, there's these little communities, and within the community, there's a little center where there's a whole lot of NGOs that work together. And we placed our container within that little yard or park kind of setting. What happened thereafter is we started seeking and recruiting trained counselors to train. So we went through the process of interviews, of finalizing the people that we'd like to join our team. And then we did a 3-week full-on training. People that joined us in this program were not necessarily trained mental health care people, but they were people that were able to, that had some sort of knowledge of working within the community. So they worked at other NGOs. Some of them lost their jobs, some of them due to COVID, some of them were able to join us because they were interested in mental health, and that was where their passion lied. So what we did was we took these individuals. We spent 3 weeks on a daily basis, training them on all different mental health conditions. Thereafter, we gave them basic counseling skills. We've given them basic presentation skills. We've trained them how to, we took them step by step on different various aspects and all the programs that we would like to run within the community. What happened next was we then started advertising our free mental health services. So we provided a service of free face-to-face counseling. That was our first step. Once we got the free face-to-face counseling up and running, what we then did is we needed to create more awareness around mental health. So we went into different areas within the community. So we went to police stations. We created a network with them so that if we ever need that support system, we could turn to them. We went to clinics. We created we created different networks with different key stakeholders within the community that provided a service. So clinics, police station, schools, other NGOs, and the main hospital that's allocated to the area as well. So what we've done was, if you can see in this slide, all the various activities that we do within the community, and you can see the main thing was free face-to-face counseling, providing a service for the community where they did not receive one. So a client would come in, explain their situation, we'd contain the situation, we'd do our basic counseling. If there is a need for referrals, we already created that network with the key stakeholders, and we could then refer them on to to a clinic or hospital where they got to see a psychologist, a psychiatrist, a physician, so that they can get the medication, treatment, or further assistance. We then established support groups because now we realized that we needed to maintain the well-being of our clients. And if we did not help maintain it, they would often relapse and not go and get the medication that they needed or the treatment that they needed. So we started opening up support groups. So we had one specifically for mental health, another support group for family members living with a loved one that had mental health conditions, because often people do need the extra support and education to help their loved ones. We have initiated a gender-based violence one because in South Africa, there's a very high rate of gender-based violence, and there were many women impacted by trauma of their relationships or their situations. So what we've done is we've done a mental health and gender-based violence support group. Thereafter, we launched a men's support group. And I think it's so powerful to do something like that because there's so much stigma around men and mental health within these communities. Men are always wanting to be the, the strong person, the provider, etc., etc. And they often ignore the signs and symptoms of what they're going through. So what we've done is we've noticed that we do get a lot of clients that are men, so we decided to start supporting them as well. We do school talks. In our school talks, we create awareness around mental illness. Suicide is one of the leading causes of death amongst youth, I think, within South Africa and worldwide. And what we've done was we have a special program called Suicide Shouldn't Be a Secret, where we speak about depression, about the pressures that student learners go through, and then obviously speak about suicide and how we could prevent it. We also did a specific program for teachers, how to handle different situations. If death impacts school due to suicide, we were there to help with the debriefing. We were there to assist teachers of how to go about creating more awareness about the resources that are available within South Africa and with SADC specifically to the learners so that they know where to turn to when they need the help they need. So our program is very comprehensive and we've seen great results from it. And we're trying to advocate for more of these containers to be put. And I think internationally, these programs can be adapted to any situation because the costing is not that much. And also the ripple effect that a container has is immense from the research we've done in our areas, and also just feedback from clients that's come to us and the people we've helped over the years. Next slide, please. So we've done, every year we do different types of research. So last year we did research across the 2 container areas that we're working in. So the 2 areas is Diepsloot and Ivory Park. We had sample size of 1,176 township residents. So what we did is we went out into busy areas like your taxi ranks, shopping centers, malls, just where there's a lot of foot traffic. And we interviewed various people of various walks of life, asking them about specific questions relating to mental health within the community. We had the age groups were almost like equal. So we had 48% of people between 18 and 35. Then we had 27% of people between 36 and 45. 25% were over 46. And when we asked them questions, it was relating to their general mental health, what type of problems they go through within their community. We asked them about what would they like as an intervention program for mental health within the community as well. It was very interesting because their 5 top challenges were crime, unemployment, substance abuse, lack of adequate housing, and COVID-19. The reason why I think crime is really bad within South Africa, and it causes a lot of trauma, a lot of anxiety. Many of the people we had interviewed were impacted greatly by the trauma that they've been through within the community they lived in. Many of them haven't received the help they need, and just finding out that there are services have encouraged them to go and get the help. We then unemployment, I think it's greatly also related to COVID-19 currently, because a lot of companies closed down, etc., which made it more difficult for them. The lack of adequate housing within these communities, if you have to see they live in little shacks, and there's not even enough gap between them because they're so densely populated. The access to running water, bathrooms, etc., is close to maybe 10%. So it is a very difficult situation for them. 10% of the people we interviewed said there is a lack of mental health services, which is absolutely correct, because when we did our survey before we entered the area, we did notice that even clinics didn't have proper psychiatric nurses, no psychologists, no psychiatrists, no GP that was well trained within mental health. So we do realize that gap, and that is why we started this program. 80% of them have not seen any mental health professional within the community. And again, it goes back to the lack of services that we have within the community. Learning about mental health, the big amount, percentages here is due to the increased amount of work we've done. So what we do is we go into clinics while people are waiting to be seen. We do mental health talks. We do, we try and educate them. So every month we have a different awareness campaign running. So we cover different topics. 70% of them seeing information via press and media. That's also because of the increase of awareness we've created within the area. So we do a lot of interviews, a lot of articles relating to mental health, just to create that awareness, but also make sure that people know there are resources and where exactly they need to reach out for the help. Social media, people are now starting to use it more often. So we do have our social media that is very active. We do share a lot of information. We cover a lot of awareness days. So some of them viewed our information via the social media. Friends and family, very often if friends and family get in contact with SEDEC, or they sit through our talks, or we do church talks as well. So wherever we try and create awareness, if they learn something, they do carry it over with them. Most of them suggested that we should increase more awareness and more education, and 27% said that we should bring more mental health services to the area. So the township areas are extremely huge, and with one container, we are servicing over 350,000 people that if they need the access to mental health, they are able to receive it, which shows that it is highly, it's very difficult to service so many people. And we are trying to encourage for more containers to be put up so that we can thereafter assist more people. Next slide. And I think we come to the end of our presentation, and I'd like to thank you. This picture that I have in the background is a team of my counselors at the container in Ivory Park. And the men that's present there were present at our first men's support group launch that happened a few weeks ago. So we are extremely happy for men to be more involved in mental health and taking care of their mental health as well. Thank you so much.
Thank you so much, Fatima. My internet was also acting up this side. Thank you for most importantly, I think culturally here, it's so important that you have your organization is focused on mental health in a space where for so long here, mental health has always been something they always tell you to just be strong and deal with. The acceptance of mental illness on community levels, and I think by extension patient levels, has been much slower in this region than I feel it should be. And things like depression and anxiety, which are things your organization really focuses on, have always been seen as rough bumps that anyone should be able to get themselves out of. So I think I speak for many people on the continent when we say thank you for focusing on this, and the statistics are quite shocking. They show that the problem is bigger than we seem to think it is. So thank you so much, Fatima.
Thank you so much.
Okay, so Fatima was our last case study. So my job here is done. I am officially handing over to the moderator to take over the discussion and lead you to the last pilgrimage. Mr. Doni? Doni? Hi, yes, you're welcome, Nelson. We've seen your message. We're also happy that you are here.
Yes, George. Thank you very much. It's Ziwa here. I'll step in to assist the moderator. We thank you for the deliberation, and would like to thank Fatima for the presentation, as well as the case studies that were shared before. Nelson, it's a pleasure having you. Thank you for joining in. We are at the point where we are going to invite people to speak about what should happen next. What do we need to do? And here we should strongly speak, because we are speaking for the patient. So our next session, as I've already mentioned, is a call to action. And this call to action is where we're going to request the team through chat and through live speaking to comment what do you think that we can do. Please give me a minute to put up a slide to showcase the anticipated outcomes. So thank you very much. So George, they have thanked you for great work done. Hope you have seen the message. So let me read it. Alex Adusei says, thanks, George, for your wonderful facilitating. Okay, you saw it. So I've been advised. So let me put here meeting objectives and outcomes. So would like to welcome first questions and insights on all the presentations that have been given. Questions, insights via chat and live speaking. Everyone is welcome to participate. Nelson, if you don't mind, we will unmute you so that you speak to us. I don't know how long you've been there. And if you have any question about the presentation, please, you can go ahead if you're okay. And anyone else who would like to speak during this time, please, you're welcome to ask questions, give insights on the case studies that have been presented, as well as the insights from Dr. Monero and Alex Adusei. You're very welcome. So there's in the chat section. Okay, Fatima thanks everyone, and she says she has learned so much. So Fatima, with that being said, what should be some of the key takeaways? I welcome you, of course, if you don't mind. What should be some of the key takeaways for SADC, but also in perspective of a patient, the perspective of the patients that you're taking care of? out of this meeting, WPA should work with the patient organizations and other stakeholders to implement certain actions. So what should be the key takeaways, key aspects that you think will impact your patient back home, where SADC has the capacity, as well as the World Patient Alliance can have the capacity to deliberate or implement such specific intervention? Thank you very much. Please go ahead.
Thank you so much. I think the most important thing is patient education, because the more I can see throughout the theme of a lot of the programs that's being done, patient education is absolutely key. So if we focus on education and providing services to areas where there are no services, those are the two big things that we need to cover. And often people are reluctant to get help because the services are very far from them. And also a lot of them don't have the education about them. So usually they get misdiagnosed. We often hear of clients going into clinics and they being sent home with just paracetamol because it will get over. But in actual case, they have a greater issue like depression or anxiety, and people are just not diagnosing properly within clinics. So I think if patients learn more about it, they can go with the symptoms and signs and sort of have clarity of what's going on. And we've noticed that within the communities we worked at, the more we taught, the more we educated, the more we spoke, people became more aware of the signs and symptoms. So when they went to get a consultation at a clinic or hospital, they were able to then relate what exactly they were going through, which made it easier for their diagnosis or referrals to go to bigger hospitals or clinics.
Thank you very much, Fatima, for agreeing to my request. Yes, Mr. Alex Adusei, it's been a great presentation. One area which can be critical is when you have cohesion among different stakeholders to implement specific interventions. And one of our short outcomes is about convening people and then later on sharing these resources. But indeed, this event has been one of the great milestones that has brought different members to come together. Before this event, possibly there haven't been other events that are similar to it with WPA. But we think just with the different presentations, the different questions that have been happened, one of the biggest outcome that was anticipated, convening the patients organization, key global development stakeholders, policy teams, industry representatives has happened. In your opinion, what do you think patients organizations and the different stakeholders can do to improve and increase cohesion amongst themselves in the aspect that we are operating in different regions and in different regions which are different locations? Cohesion and the outcome of the cohesion, plan interventions for the patients. If you can, of course, speak to it. If you cannot, there's still no problem. Yes, Mr. Adusei, are you still there? So, hey, Mr. Adusei is still there. Let me see if I can get him. Yes.
Yes, can you hear me?
Yes, we can hear you, sir.
Yes, my perspective on your question is that if possible, because it's all about implementation. So if possible, the duty bearer, that is the government institutions, and then the private and also the individual patients, the families would establish, a close collaboration, working collaboration. It will go a long way to establish the cohesion you are talking about, because the link is not there. There is a huge gap because the government institution is doing their own, because there's a commitment, and their political commitment is to put their own agenda. So if possible, they will integrate the input from all the stakeholders, like from the CSO, from the private, and then also the traditional, and then the religious people. It will go a long way to help this cohesion to work great.
Thank you very much, sir. That's really very insightful. I'll read a comment or an insight from Mr. Emmanuel Aire. I hope I've pronounced the name right. He's saying Ghana is implementing the community scorecard developed and technically supported by the African leaders, Malaria Alliance. I think they did present a scorecard before, but I'm not so sure whether it's similar to this. Emmanuel, can we unmute you so that you speak to this if you don't mind? Let me. Emmanuel, okay, here. It works. Hello, Emmanuel. Hello. Okay, maybe Emmanuel.
Hello.
Yes, Emmanuel. Oh, thank you. Welcome.
Yes.
Please speak to your point, emphasize it.
Yeah, so I was saying that Ghana and other few countries are implementing the community scorecard, which is supported by the African Leaders Malaria Alliance. The community scorecard is a web-based, color-coded tool that is implemented. And for Ghana, this was implemented using key indicators, quality of care indicators, which were 9, which included cleanliness of the facility, safety of the facility, availability of logistics, the quality of the national health insurance scheme, that is a national insurance scheme in Ghana, whether it's functioning very well as expected at a community level. And then it also included whether they were happy with the services provided at the facility, whether the health staff are friendly and respectful, they're providing dignified care at the facility, and among others. And sections, there's a selection of key opinion leaders across the community that convene quarterly to assess each facility on these 9 indicators. When the platform is provided, I can provide further highlights since you are running out of time. So these indicators are scored by the Community Health Management Committee members on a scale of 1 to 3. And the indicators after the scoring are entered into the DHIS, validated, and then uploaded through an app into the main web-based platform to provide that color coding, and green for good, and then yellow for somehow, and then red as a summary of that indicator at the facility not doing well, or the community not being happy with it. And after the scoring, reasons are assigned to each indicator for the score. And then an action plan is developed by the community to implement what they can do to improve the health status in their jurisdiction. And this is what happens. So the scorecard, the scores are entered into the web-based platform, and the community members have access to their scores. And then the action plan is also uploaded into the action tracker of the web-based platform. And then on the quarterly basis, they assess to see whether they've been able to implement the action to improve or not. And the good thing about this is that there's also an interface meeting after the scoring with the health management to give them feedback about their scores, for them to respond and also develop actions to improve on the areas they haven't done well as a health system. And this goes right from the lowest level, the community, to politicians, to donors, partners, development partners, civil society organizations, and even to the media, to parliament, and to the presidency on how they are doing on all the key prioritized indicators at the community level. So it provides very good information for parliamentarians and planners to develop actions in improving on the health status at the community level. So this is what the scorecard is all about.
Thank you very much, gentlemen. Those are all interesting insights. And in fact, one of the long-term key outcomes from this meeting, as you can notice, that create an online information sharing and knowledge management portal for tracking progress of universal health coverage interventions, map and form a network of the African continent patient advocacy working groups. Now, for all participants that have managed to join today, we'll solicit for contacts, we'll solicit for information so that we join our efforts. In the meantime, I would like to welcome Rebecca if she can. She says that I'm very keen on issues of mental health exacerbated by many factors socially and emotionally, and more so drug abuse. My concern is the lack of appropriate service treatment to the patient of drug addictions. For example, the patients are just admitted into psychiatric wards and not rehabilitated. And Rebecca, when you speak about it, it's an issue that is usually, it's a disease agenda that is usually skipped. And one of the curiosities that we can usually have is that when we talk about mental health, actually, you find that maybe the corporate social class has a high regard and tries to find solution around it. How about that patient who is isolated? But please, Rebecca, can you say one or two words about what you have put in the chat, if you can, of course?
The notes in the chat.
Rebecca, I've unmuted you. I don't know whether it's you that are okay here. Rebecca, can you speak to us? If not, it's still fine. Okay, maybe Rebecca might not speak to us, but still on the different disease agendas and how they are addressed with different social groups, because the patient is existing in different social groups. You know, you have people who want some income, then there's the poorest communities. Christine, if you can, in one of the conversations we are having with a group of patients organizations, they say that the disease agendas are evolving, and so many have come up, so many have been there, and even the old ones are still very hard. When we talk about rare disorders, you barely find at events when they speak about the rare disorders, not even in the literacy materials. Maybe in Kenya it exists, but it's not common that you'd find interventions speaking about disorders. And I think, in my opinion, of course I could be wrong, but the different disease agendas that are happening, and there are people who are actually affected by these different disease agendas. There are people who are actually doing such great work like the rare diseases, Kenya towards the rare disorders. Christine, in your opinion, how can we make sure that we have an encompassing, how do we call it, a way to capture everything that happens and affects patients? Because, like, once again I mentioned, for disorders, it's very rare that you have people present about it during health events. Same to mental health. Mental health is assumed to be a madman running on the road, but Rebecca says people have issues. It's even the environment. It's even, please, Christine, go ahead if you don't mind.
Okay, Ziwa, am I unmuted now?
Rebecca, you're welcome. Please, Christine, pardon me. Let Rebecca speak, and then you can come in. Hopefully that gives you time. Yes, Rebecca, tell us.
Yeah, issues of mental health have become very prevalent of late, ranging from emotional abuse, domestic violence, gender-based violence, drug abuse, and so on. Even the COVID pandemic itself left a lot of people with issues on mental health. My concern really is, are we handling these issues professionally, or are we giving them the right treatment that they deserve? What I've noticed with drug abuse, for example, is that people are just taken into psychiatric wards and treated like any other mental case without actually rehabilitating them and, you know, treating them or making sure that the addiction is treated. So amongst many other mental health issues, my concern is, are we giving them enough or the appropriate type of treatment that they deserve? And the increase is noticeable, not just here in my country, but I think it's happening everywhere. And it's not an area that we prioritize as health practitioners most of the time. That's my take, Siwa.
Thank you very much, Rebecca. Just one quick inquiry. In your opinion, being a member of a patient organization, and through this also participating on this convening that is putting together different patient organizations, what do you think can be some one or two actions that can be implemented within, for example, the limits of your organization, within the limits of the World Patient Alliance? What's your call to action? What do we need to do on these unregarded issues like mental health?
I think we need to prioritize issues on mental health. We need to put more focus on that. Maybe even hold a day's workshop based on just mental health without necessarily talking about all the other health issues that we have. It's really a concern because this can be a permanent damage to someone if we don't take it more seriously. So I feel we need to give it more attention, more priority, and tackle it independently from all other issues that we have discussed today.
Thank you very much, Rebecca, for those insights. Now, because we're indeed running out of time, I'll stop here. But before I stop, I would like to mention that from this event, we still expect to call upon, is Christine still there? Sorry, I think Christine she's not going to, okay. Oh, she should have gone. So we could have hoped that we would stay longer, but we'll need to welcome Regina to do a wrap up. But before the wrap up, there's one important thing is that even at the end where we have you see so many discussions, which might imply that there's need for more engagement, need for more to create call for action. But here I will quickly invite Harris, 1 or 2 minutes. Harris, the people I assume on this platform who are not the World Patient Alliance members, maybe one way to now start getting them on, them sharing these platforms is knowing how does one become a member, and then after the event, how do they contact us? If you can, of course, speak to it. And then Regina will come in and do the wrap up and close. If you can't, then we'll just move to her. Thank you very much. Oh, okay. It seems Harris is not available, but due to time limitations, we will.
Sorry, I was here. I was unable to unmute because Donnie was the host. So if anybody wants to become a member, so the procedure is simple. We have a page on our website which named as Join Us, and you can go over there and you can fill out the membership application form, and it will hardly take 5 to 10 minutes, and all the details are given over there. After receiving the membership application, I forward it to our membership committee. Membership committee reviews it, and when they give approval, then we forward it to our full board, and our full board gives the approval. So after getting the approval from full board, I send back the membership acceptance letter to approved member. This is the procedure. So we will be more than happy to have you, your organization, if anybody is interested to become our member. So we would be more than happy to have you on WPA membership.
Thank you very much, Harris. We now welcome Regina to close the event and wrap up with some insights.
Thank you very much, Ziwa, and I just want to thank everyone. It's been a day of learning, sharing. I can't thank you enough. It's really humbling. People who have been with us since morning, I must say it's very humbling. We want to thank the organizing committee once again. We want to thank WPA, most especially the speakers. Our sincere thanks for accepting our invitation and being able to participate and make those presentations. Our session chairs, our moderators, we just want to thank you. I mean, we can't thank you enough. It's been a day of learning. And for me, quite a number of issues have touched me right from the beginning, from the storytelling, the need, which emphasized the need for supportive environment. Ernest's powerful work in the Ministry of Health to ensure patients are safe. Dr. Gertrude from WHO, the amazing efforts by WHO to ensure that patients are not harmed in care, the priority that has been given patient safety, and the global action plan, especially focusing on the patient and family in the strategic objective 4. And again, Alex coming in and calling on us to implement this in Africa, the need to integrate this in our work, just as Ernest highlighted the work they are doing in Ghana. There's need for ministries of health and all of us, all the key stakeholders to integrate patient safety. For me, as a patient safety champion, I'm very glad that it is being put on the table at the center and being prioritized. Then we had farm access, strengthening supply chain. We all know the challenges, the ecosystem approach and the stepwise approach by farm access, for me, was really amazing to ensure sustainable healthcare. Again, Dr. Jane Biaruhanga told us about the need for primary healthcare. We cannot overemphasize, because we know that issues, the practical realities actually happen at the primary healthcare, and the need to strengthen that infrastructure at that level is very, very, very critical. The skilling of community health workers and education and awareness at that level by AU, NEPA, Dr. Biaruhanga, that was really, really appreciated. The Max Foundation and its very, the 25 years of accelerating health equity in memory of Max, and providing sustainable solutions through their model, logistics, treatment, the network of healthcare professionals, and the in-country team, where the patient is at the center. For me, that really made my day. Then again, the case studies from the rare disease, cancer, SADAG, chain, HIV, we had Monela, Ziwa, Fatima, Irene, and Christine. The emphasis on the need for patient empowerment and engagement, issues of health literacy. They highlight the challenges they face, which all, and particularly heightened by COVID-19, the need for us to come together, the need to work together, the need to be our own champions. The issue of data, as highlighted by Dr. Gertrude, was also very critical. We do a lot of work. You've heard all the different case studies by the different organizations, but many times we don't document. In Africa, there's a glaring gap on data, on evidence research and evidence-based interventions. It's time that we document everything that we do. It's time that we start collecting the data and be able to provide evidence-based interventions. The whole issue of sustainable solutions was very key, like I said, from Max Foundation, and the call on partners, collaborations, public-private partnerships, all the key stakeholders, the patient organizations, is all a key issue to continue discussing. This has been a very good platform. We're going to continue engaging. the relationships, the networks we are forming from this meeting, we do not want them to end here. We are not looking at this as a one-time event. We want to continue what we want to focus on our long-term outcomes for this meeting and ensure that we do not just talk. I have a friend of mine who called it NATO, no action, talk only. We don't want to be NATO. We want to be action-oriented and ensure that we all work together to ensure that the patient is at the center of healthcare through empowerment, through engagement, through provision of an environment, providing them with the support. On the other hand, each one doing their role. Government providing enough funding, providing universal health coverage through increasing the budgets, national health insurance, and others. So I just want to take this opportunity once again to thank everyone who has taken their time to be part of this meeting, made contributions, and participated in any way that has made this meeting a success. Thank you very much. I want to thank everyone who has been part of this. Thank you all. And I think with those few, not so few words, I want to close this meeting.